welcome all of you to PrepLadder's FMG LLR session for biochemistry. And this session will be a high yielding session. And what can you expect in this session? Every MCQ that will be discussed in this session will be a previous year question. And all these previous year questions will be based on the most commonly asked topics, right? So as you all know, most of the questions for FMG, thank you all of you. So most of the questions in FMG come with vitamins. So in this session, I have chosen few previous year questions based on vitamin deficiency disorders and diagnosis. And in the last Jan 2024, just in one paper, there were 4 questions on ABG. So I will be discussing an outline on how to interpret ABG reports. Many questions are asked on alcohol metabolism. We will discuss about glycogen storage disorders, glycosphingolipidosis, porphyrias, mucopolysaccharidosis. Okay. So additionally, I'll be telling about blood collection tubes and molecular biology techniques. Okay, so this is what you can expect in this session, and based on this session, most of the questions will be asked. Okay, thanks everybody. And this is the first question for all of you. Interpret the following values provided in the ABG report. They've given you pH, PCO2 and bicarbonate. And before you start interpreting, I hope all of you, I just try to answer this. They've given you pH, PCO2 and bicarbonate. First, you need to know normal values. What is the normal pH? Normal pH is 7.36 to 7.44, right? Normal PCO2. What is the normal PCO2? Take off the 7. So it is 36 to 44 millimeters of mercury. What is the normal bicarbonate? Normal bicarbonate is 24. On either side you can have 3, which means normal bicarbonate is 21 to 27 milliequivalents per liter. So these are the normal values that everybody should know by heart. So can you all repeat this along with me? What is the normal pH? The normal pH is 7.36 to 7.44. Normal PCO2, take off the 7, so it is 36 to 44 millimeters of mercury. Normal bicarbonate is 21 to 27 milliequivalents per liter. So it is milliequivalents per liter. These are the normal values. Okay. So what is the step number 1? I'm going to just tell you 2 steps based on which you'll be able to answer all ABG questions. Okay. Step number 1 is to check the pH. Okay. You have to check the pH. We know that the normal pH is between 7.36 to 7.44. So what if the pH is less than 7.36? If it is less than 7.36, very good. The answer is acidosis. What if the pH is more than 7.44? It means the person has got alkalosis. But this does not mean that the normal pH between 7.36 and 7.44 excludes an acid-base disorder. A person can still have a normal pH but suffer from an acid-base disorder. Okay, so normal pH between 7.36 and 7.44 does not exclude an acid-base disorder. It can be potentially a combination of acid-base disorders. For example, what if the person has got a combination of metabolic acidosis and metabolic alkalosis? If the person has got a combination of metabolic acidosis and metabolic alkalosis, in that case, pH will be within the normal range. So even when the pH is normal, please go ahead and check bicarbonate and PCO2. Only when all 3 values are normal, you can say that the person is in a normal acid-base homeostasis. This is step number 1 to find out whether it is acidosis or alkalosis. Okay. Now, to find out whether it is metabolic or respiratory, we go to step number 2. So, to find out whether it is metabolic or respiratory, you should check PCO2 and bicarbonate. Okay, you should check PCO2 and bicarbonate. Now, how do we proceed in this step? First, I'm going to tell you what to do when it is acidosis. Then, I will tell you what to do when it is alkalosis. Okay, acidosis can be because of 2 reasons. One is, it can be because of a decrease in bicarbonate. Why should a decrease in bicarbonate cause acidosis? Because bicarbonate is a major plasma buffer. So for any reason, if this buffer is missing, all metabolic acids will accumulate. When metabolic acids accumulate, we call that condition as metabolic acidosis. So if you see low pH that is caused by a decrease in bicarbonate, then what is it called as? Metabolic acidosis. Acidosis can also be because of high PCO2. Why should a high PCO2 cause acidosis? Because carbon dioxide is a source of acid. So for any reason, if carbon dioxide accumulates, that causes acidosis, and that is called as respiratory acidosis. So are you clear about acidosis? If acidosis is because of decrease in bicarbonate, it is metabolic acidosis. If it's because of increase in PCO2, it is respiratory acidosis. Now what about alkalosis? Alkalosis can be either because of increase in bicarbonate or a decrease in PCO2. If a high bicarbonate causes alkalosis, then that is called as metabolic alkalosis. If a low PCO2 causes alkalosis, that is called as respiratory alkalosis. If you follow these two steps, you will clearly understand whether a person has got metabolic or respiratory, whether a person has got acidosis or alkalosis. Okay. Now look at these values. All of you tell me the right answer. What is the pH here? The pH here is low. So we know it is a case of acidosis. So what are the choices that you can exclude? Exclude metabolic alkalosis and respiratory alkalosis. Okay. Now check bicarbonate. What do you see about bicarbonate? There is a decrease in bicarbonate. I said normal value is 21 to 27 milliequivalents per liter. Here it is low. And what if there is low bicarbonate and acidosis? It is metabolic acidosis. Are you all clear about this? Excellent. Very good. Yeah. So the answer for this question is metabolic acidosis. It's a previous year question. Now if it's asked, you will be able to answer this. Okay. Can we proceed to the next question, all of you? This is the next one. How to calculate compensation. Yes, I will tell you about compensation at the end of the session. For compensation, there are few calculations. How many of you want to know about compensation, all of you? If you want to know about compensation, please give a thumbs up. Let me start explaining in that case. How many of you want to know about compensation? Okay, many of you want to know about compensation. Let me explain that to you. No worries. 1 second. Let me add a slide. Yes. So about compensation, okay, there are two facts that you need to know about compensation. The first fact is, thanks all of you, thank you. I'm very happy to see that all of you are interested. So there are two facts that you need to know about compensation. I'll give you an example for you to understand those two facts. If it's metabolic acidosis, okay, whenever the primary disorder is metabolic, what will come for the compensation? Lungs will come for the compensation. Whenever the primary disorder is respiratory, what will come for the compensation? Kidneys will come for the compensation. Are you clear? If the primary disorder is metabolic, lungs will come for the compensation. If the primary disorder is respiratory, kidneys come for the compensation. Okay? And the compensation is always parallel. For example, if it's metabolic acidosis, what is metabolic acidosis? Decrease in pH caused by a decrease in bicarbonate, right? Metabolic acidosis is decrease in pH caused by a decrease in bicarbonate. Then what should be the compensation? The compensation should be a decrease in PCO2. Compensation is parallel. It should be a decrease in PCO2. And if you're asking me how can a decrease in PCO2 help in compensation? Because as I told you, carbon dioxide is a source of acid. So in metabolic acidosis, if you get rid of a source of acid, then the acidosis will be compensated. So the compensation is a decrease in PCO2. Okay. How much decrease in PCO2 do you anticipate? Expected PCO2. Yeah, expected PCO2 in metabolic acidosis is 1.5 into bicarbonate plus 8. So tell me, what is the formula that is used to calculate compensation in metabolic acidosis? All of you please memorize it. In metabolic acidosis, you expect a decrease in PCO2 and the expected PCO2 is 1.5 into bicarbonate plus 8. Okay, let me give you an example for this. pH of your patient is 7.3. So what is it? This is acidosis. Bicarbonate of your patient is 21, no, bicarbonate of your patient is 18. Okay, it is 18 milliequivalents per liter. So what is your diagnosis? It is acidosis caused by a decrease in bicarbonate. So it is metabolic acidosis. Now what is the expected compensation? Expected compensation is a decrease in PCO2. How much decrease in PCO2 do you anticipate? Expected PCO2 is 1.5 into bicarbonate plus 8. So what is 1.5 into 18? It is 27. 27 plus 8 is 35 millimeters of mercury. So for these two values, expected PCO2 is 35 millimeters of mercury. Okay. What if the actual PCO2? This is expected. But what if the actual PCO2 of your patient is still 40 millimeters of mercury? From 40, you expect the PCO2 to have declined to 35. That is expected. But you see that it has not declined at all. It is still 40, which means it is uncompensated. It means it is uncompensated metabolic acidosis. If the ABG report shows an actual PCO2 of 40 millimeters of mercury against the expected decrease of 35, then your answer would be uncompensated metabolic acidosis. Are you clear? Yes, Winter's formula. Excellent. Now, what if the actual PCO2 in the report says it is 35 millimeters of mercury? If the actual is the same as expected, then what will be your answer? You will say it is compensated metabolic acidosis. Got it? Third scenario. What if the actual PCO2 of the patient was 30? Okay, from 40 you expect it to have declined to 35. But you see the actual PCO2 to be 30. Then what would you say? Don't say it is overcompensated. Your body never overcompensates. So if you see the PCO2 to have declined more than what is expected, it means there is a hidden acid-base disorder. There is another acid-base disorder which is causing a further decline in PCO2. Which other acid-base disorder will cause a further decline in PCO2? That is respiratory alkalosis. So this is a case of metabolic acidosis with respiratory alkalosis. Are you all clear? If it's clear, can I see a thumbs up, please? It means it's a case of metabolic acidosis with respiratory alkalosis. You have found out a hidden acid-base disorder in this case. And this is how you calculate compensation. So are you clear? So tell me the formula for metabolic acidosis. Expected PCO2 is, please don't. This is definitely necessary for FMG. Yeah. So let me tell you this. I have referred to all last 4-year question papers. Based on that, the discussion is happening. Okay. And FMG papers are not to be underestimated. In FMG, every possible question is asked. I have seen in FMG questions which are more complicated than what is seen in NEET PG. So there is no harm in calculating compensation and understanding all these disorders. Yeah. So let's be enthusiastic about what we are learning. Okay. More you learn, better are the chances that you clear FMG exam. So let's stay positive. Yeah. So I will not waste your time. I will not waste your time. I will not waste my time. Got it, all of you? Yes. So this is a combination of metabolic acidosis and respiratory alkalosis. Got it? So this is about metabolic condition. Now, what if your patient has got metabolic alkalosis? Say the pH of your patient. Yeah, pH of your patient is 7.46, which means it is alkalosis. And the person's bicarbonate happens to be 30 milliequivalents per liter. Yeah, person's bicarbonate happens to be 30 milliequivalents per liter. So high pH accompanied by high bicarbonate, which means it is metabolic alkalosis. For metabolic alkalosis, what is the expected compensation? Expected compensation is an increase in PCO2. Now, what is the expected increase in PCO2? Expected PCO2 in metabolic alkalosis is 0.9 into bicarbonate plus 16. Are you clear? 0.9 into bicarbonate plus 16. So in this case, it is 0.9 into 30 plus 16, which is 27 plus 16. And that is 43 millimeters of mercury. So expected PCO2 is 43 millimeters of mercury. What if the actual PCO2 was 40? If the actual PCO2 was 40, it means it is uncompensated metabolic alkalosis. Do you understand this? From 40, it should have increased to 43. It has not increased, which means it is uncompensated metabolic alkalosis. What if the actual PCO2 was 43 millimeters of mercury? It is compensated metabolic alkalosis. What if the actual PCO2 was 50 millimeters of mercury? Your body does not overcompensate. So if you see overcompensation to have happened, then what will be your answer? There is another hidden acid-base disorder which is causing a further increase in PCO2. Which acid-base disorder will cause a further increase in PCO2? That is respiratory acidosis. So this is a case of metabolic alkalosis plus respiratory acidosis. Are you clear? This is how we calculate compensation. Okay. So try answering this question. A neonate presents with recurrent projectile vomiting which is non-bilious. What is the electrolyte abnormality that is expected in this condition? Very good. So do you have any doubt about hypochloremia here? It has to be hypochloremia because a person is vomiting out acid. So there will be hypochloremia. Additionally, there will be hypokalemic metabolic alkalosis. So let me tell you, why should projectile vomiting cause hypokalemic metabolic alkalosis? The answer for this question is choice B, but why? It is because when a person is vomiting, there will be dehydration. All of you listen to this because this projectile vomiting MCQ is being repeatedly asked. So whenever there is projectile vomiting, what happens? The person will be severely dehydrated. When there is severe dehydration, JG apparatus will be stimulated. That releases renin. Renin synthesizes angiotensin II. Angiotensin II causes aldosterone secretion. Now, what does aldosterone cause? Even if you don't remember it till now, please understand this. Aldosterone acts on the distal convoluted tubule when it causes sodium and water reabsorption. Isn't that what you want? Whenever there is sodium and water reabsorption, the dehydration component will be overcome. So, secondary hyperaldosteronism. Aldosterone causes sodium and water reabsorption to compensate for the dehydration. But reciprocally, aldosterone causes potassium and H plus secretion. Aldosterone reabsorbs sodium and water, reciprocally causes potassium and H plus secretion into the urine. What will happen when potassium is secreted into the urine? There will be hypokalemia. What if H plus ions is secreted into the urine? That will cause metabolic alkalosis. And that is why in severe or projectile vomiting, you see hypochloremia because chloride is getting lost. Hypokalemia because of secondary hyperaldosteronism. Metabolic alkalosis again because of secondary hyperaldosteronism. So nobody should forget this. Projectile vomiting causes hypochloremic, hypokalemic metabolic alkalosis. Okay. 1 second. What about diarrhea? Yes, diarrhea causes metabolic acidosis. Okay, please remember, diarrhea causes normal anion gap metabolic acidosis. And if you're asking me why, because in diarrhea mucus gets lost and mucus is rich in bicarbonate. Every time you lose bicarbonate, you're losing a buffer that causes metabolic acidosis. Sure, I will repeat it. What is the reason for secondary hyperaldosteronism here? Whenever there is vomiting, the person is losing water. Losing water causes dehydration. Dehydration causes JG apparatus to be stimulated. Renin is released. Angiotensin II is produced. Angiotensin 2 causes aldosterone secretion, right? What does aldosterone cause? Sodium reabsorption. Reciprocally causes potassium and H plus secretion. When potassium is secreted, it causes hypokalemia. When H plus is getting secreted, you losing H plus into urine. So that causes metabolic alkalosis. Are you clear, all of you? Muhammad Islam, Muhammad Zain. Have you all understood this? Yes, good. So vomiting causes hypochloremic, hypokalemic metabolic alkalosis. What about diarrhea? I said diarrhea is a loss of mucus. Mucus is rich in bicarbonate. Every time you lose bicarbonate, it causes metabolic acidosis. And that is normal anion gap metabolic acidosis. Good. So another MCQ on ABG, in arterial blood gas analysis, which of the following is derived or calculated? So in any ABG machine that you see, we have only 3 electrodes. One electrode to measure pH, one electrode to measure PCO2, one electrode to measure PO2. And based on these values, bicarbonate will be calculated. So the bicarbonate value that you see in the ABG report will be written like this. C bicarbonate. What does C here stand for? Calculated bicarbonate. Excellent. Answer is D. Zellweger syndrome is due to which of the following disorders? Zellweger is a peroxisomal disorder. Do you understand this? Answer is peroxisome. So peroxisomal biogenesis disorder is Zellweger syndrome, and it is caused by the defect of POX gene. POX gene mutation causes Zellweger syndrome, and this is called the cerebrohepatorenal syndrome. Please memorize it. What is it called? The cerebrohepatorenal syndrome. Yes, peroxisome is related to beta oxidation of very long chain fatty acid. So in Zellweger syndrome, there is defect of beta oxidation of very long chain fatty acids. Please tell examples of normal anion gap. So high anion gap metabolic acidosis, normal anion gap metabolic acidosis. Okay. Normal anion gap metabolic acidosis is because of diarrhea, or it is because of renal tubular acidosis. Can you memorize this? Normal anion gap metabolic acidosis because of diarrhea and because of renal tubular acidosis. Other than these two causes, every other cause of metabolic acidosis will be high anion gap. Does that help all of you? Does that help? Yes. So this is about normal anion gap metabolic acidosis. High anion gap metabolic acidosis will be all other causes. And what is the formula for anion gap? That is another question. Anion gap is calculated as sodium minus chloride and bicarbonate put together. Anion gap is calculated as sodium minus within brackets chloride and bicarbonate. Normal anion gap is 12 plus or minus 2. Right? Normal anion gap is 12 plus or minus 2. If it is within this range, it is normal anion gap, which means it's because of diarrhea or it is because of renal tubular acidosis. I hope I've clarified all your doubts. Any doubt can be asked in the chat anytime, right? I'm more than happy to help you out. So which of the following deficiencies is associated with poor wound healing? Dermatitis, diarrhea, and alopecia. I'll second. So all these are previous year questions, all of you. Okay, I hope you are able to see it now. So this is a July 2023 MCQ. Poor wound healing, diarrhea, dermatitis, and alopecia. I'm seeing multiple answers here. The answer is zinc. Okay, the answer here is zinc, choice C. So whenever you see the term poor wound healing, you should think of either zinc deficiency or vitamin C deficiency. Do you understand this? Zinc deficiency and vitamin C deficiency can cause poor wound healing. Though there are two causes, and in the MCQ you see both the causes, there is not only poor wound healing, there is also dermatitis, diarrhea, and alopecia. This is the triad. This is the triad to make diagnosis of zinc deficiency. For zinc deficiency, please remember acrodermatitis enteropathica. Yeah, zinc deficiency causes acrodermatitis enteropathica. What does it mean? Acrodermatitis is peripheral dermatitis. So in the periorificial region, you will see dermatitis. That's why acrodermatitis. Enteropathica meaning intestine gets affected, so there will be diarrhea. And there will also be alopecia. Put together, that's a triad used for diagnosing zinc deficiency. So poor wound healing, what are the two deficiencies that you should remember? One is zinc, the other one is vitamin C. And why zinc deficiency causes poor wound healing? Because zinc is necessary for metalloproteinases. And these metalloproteinases are necessary for wound healing. But why should vitamin C deficiency cause poor wound healing? Because vitamin C is necessary for collagen maturation. Do you understand this? Vitamin C is necessary for collagen maturation. So about collagen maturation, please remember we need vitamin C and copper. For collagen maturation, you need vitamin C and copper. Vitamin C is necessary for prolyl hydroxylase and lysyl hydroxylase. Okay, vitamin C is necessary for prolyl hydroxylase and lysyl hydroxylase, both of which are necessary for collagen cross-linkage formation. Copper is necessary for lysyl oxidase. That is also necessary for collagen maturation. So whenever you see poor wound healing, what will you think of? Zinc and vitamin C. Are you clear? Poor wound healing is zinc and vitamin C. Collagen maturation is vitamin C and copper. So the next question is, a child presents to the clinic with fatigue, joint pain and swollen gums. Physical examination reveals petechiae on her skin. Excellent. Yes. So it is scurvy because of vitamin C deficiency. So why should vitamin C deficiency cause bleeding? Because just now I told you vitamin C is necessary for collagen maturation. Without collagen maturation, the subendothelial tissues will become weak. So blood vessels are weaker, and that is why you see petechiae, right? And that is why you see bleeding gums. Good. A patient presents with a combination of Castle's necklace. The moment you see Castle's necklace, what will you think of? Niacin deficiency of pellagra, right? 3 Ds of pellagra. What are the 3 Ds of pellagra? Diarrhea, dermatitis and dementia. And for dermatitis, what will you remember? You will remember Castle's necklace. So Castle's necklace, cheilitis and stomatitis. Upon further investigation, excellent all of you. Who said? Mohammed Amir, it is not vitamin C deficiency. Castle's necklace is a part of pellagra. Okay, upon further investigation, it is discovered that the individual has a diet deficient in a specific nutrient. Which specific nutrient is deficient in the diet? It is tryptophan deficiency. So tryptophan deficiency causes niacin deficiency. Niacin deficiency causes 3 Ds of pellagra. So those of you who are attending FMG exam should learn definitely about pellagra, because I've seen so many questions on pellagra. So let's learn about niacin. What is niacin? Niacin is vitamin B3. And niacin or vitamin B3 deficiency causes 3 Ds of pellagra. Easy to remember, right? Niacin is vitamin B3 deficiency causes 3 Ds of pellagra. What are the 3 Ds of pellagra? Diarrhea, dermatitis and dementia. Okay. And dermatitis, what will you remember? Castle's necklace. Can you see that? This is Castle's necklace, which is a hyperpigmented skin lesion which is seen in the sun exposed area. This is called as Castle's necklace. And it is caused by tryptophan deficiency. Very good, Ojas Krantilal. 60 milligram of tryptophan is equivalent to 1 milligram of niacin. So tryptophan deficiency causes niacin deficiency because niacin is one micronutrient that is synthesized in your body from tryptophan. okay, from tryptophan. I'm going to tell you all about that, Falguni, no worries, okay. So, a bit about tryptophan conversion to niacin. I'm not going to tell you all steps of niacin synthesis. All that I want you to remember is from tryptophan, through many steps, it gets converted to quinolinate. Yeah, from tryptophan, through many steps, it gets converted to quinolinate. This quinolinate, in the presence of quinolinate phosphoribosyl transferase, then becomes niacin. And for the conversion of tryptophan to niacin, we need vitamin B6. For the conversion of tryptophan to niacin, we need vitamin B6. Now, what are the causes of pellagra? What are the causes of niacin deficiency? Let's learn that, okay? The first cause would be, for pellagra, the causes will be dietary deficiency of niacin. Logical, right? It can be because of dietary deficiency of niacin, or it can be because of dietary deficiency of tryptophan. When will there be tryptophan deficiency in the diet? Maize-based diet, right? Maize is very low in tryptophan, so anybody who's on a maize-based diet will end up getting pellagra. And even if the tryptophan in the diet is adequate, what if tryptophan is not absorbed properly? That causes pellagra. So it is tryptophan malabsorption syndrome. So tell me, what is tryptophan malabsorption syndrome? It is Hartnupp's disease. Do you all understand this? It is Hartnupp's disease. So Hartnupp's disease is caused by the defect of a transporter, which is responsible for tryptophan absorption along the intestine and for tryptophan reabsorption along the renal tubules. So both these are through one common transporter. When that transporter is defective, tryptophan is not absorbed, and that causes pellagra. Because tryptophan is not getting reabsorbed along the renal tubules, there will be amino aciduria. So whenever the history says 3 Ds of pellagra, all of you please listen to this. All these have been previously asked in FMG. Okay, 3 Ds of pellagra with amino aciduria. Urine has amino acids. If you see this combination, then what will be your answer? Your answer should be Hartnupp's disease. Okay. Now, what if tryptophan is absorbed? But after absorption of tryptophan in the body, tryptophan is used for serotonin synthesis. So, tryptophan is a common precursor for both niacin and for serotonin. In carcinoid syndrome, all the tryptophan will be used only for serotonin synthesis. So, tryptophan is not available for niacin synthesis. That also causes pellagra. So, not only Hartnupp's disease, carcinoid syndrome can also cause pellagra. Do you all remember this being asked in Jan 2024 FMG? The question said 3 Ds of pellagra, but urinary 5-HIAA concentration was normal. Yeah, urinary 5-HIAA concentration is normal, meaning it is not carcinoid syndrome. Yeah, so please remember, carcinoid syndrome is one of the causes of pellagra. Okay, everything is good. Tryptophan is absorbed. Tryptophan is used for niacin synthesis. But what if there is B6 deficiency? Right? What if there is B6 deficiency? That will also cause pellagra, because I told you B6 is necessary for the conversion of tryptophan to niacin. Finally, what if quinolinate phosphoribosyl transferase is inhibited? What inhibits quinolinate phosphoribosyl transferase? Leucin. Okay, leucin and amino acid inhibits quinolinate phosphoribosyl transferase, causing leucin pellagra. When will leucin be high in the blood? Whenever a person is on sorghum-based diet, like rice, wheat, maize, we also have sorghum. So if a person is on a sorghum-based diet, in sorghum, leucin availability is high. And that leucin inhibits quinolinate phosphoribosyl transferase, causing leucin pellagra. Are you all clear? Yes, 5-HIAA is elevated in carcinoid syndrome, Pratiksha, because that is elevated in carcinoid syndrome. So, carcinoid syndrome can be excluded by you estimating urinary 5-HIAA. Okay, so can you all tell me what are the causes of pellagra? Number one cause of pellagra will be dietary deficiency. Can you all type that in the chat box, please? One is niacin deficiency in the diet. Number two, tryptophan deficiency in the diet, which is maize-based diet. Tryptophan malabsorption, which is Hartnupp's disease. You cannot see the last line. I have not written much in the last line. I've just written quinolinate phosphoribosine transferase. Okay, so niacin deficiency in the diet, tryptophan deficiency in the diet, which is maize-based diet, tryptophan malabsorption, which is Hartnupp's disease, and then carcinoid syndrome, B6 deficiency, and leucin pellagra. Leucin inhibits quinolinate phosphoribosine transferase. Sorghum is rich in leucin, so sorghum-based diet will cause pellagra. Carcinoid syndrome. Nothing to explain about carcinoid syndrome. I want you to know that tryptophan becomes 5-hydroxytryptophan. This 5-hydroxytryptophan on decarboxylation becomes 5-hydroxytryptamine, which is serotonin. So in carcinoid syndrome, all the tryptophan in the diet will be used only for serotonin synthesis. So tryptophan will not be available for niacin synthesis. So carcinoid syndrome is a cause of pellagra. But how will you know whether it is carcinoid syndrome or not? If a person presents with 3 Ds of pellagra, you estimate urinary 5-HIAA. What is 5-HIAA? 5-hydroxyindole acetic acid. That's a metabolite of serotonin. In carcinoid syndrome, 5-HIAA will be high. So if urinary 5-HIAA is normal, you have excluded carcinoid syndrome. If urinary 5-HIAA is high and there is pellagra, then it is carcinoid syndrome. Are you clear? Okay. So next, please, all of you, check this one. A patient presents with a combination of, so please tell me the right answer here. A patient presents with a combination of Cassell's necklace, cheilitis and stomatitis. So it is niacin deficiency, which is caused by probably maize-based diet. No, Anisha. 5-HT is serotonin. Serotonin is 5-hydroxytryptamine. That is a neurotransmitter. 5-hydroxytryptamine on metabolism becomes 5-hydroxyindole acetic acid. Do you understand this? I am writing it for the benefit of all of you for future PDF as somebody had asked here. So 5-HT is serotonin, 5-hydroxyindole acetic acid. Are you clear? 5-hydroxyindole acetic acid is a metabolite. It's a metabolite of serotonin. Anisha, have you understood this? So try answering the next one. So all these are repeat questions. FMG June 2021. A person presents with diarrhea, dermatitis and dementia. What is the probable cause? Yes, pellagra. Good. Which of the following is a precursor of niacin? Can you answer this, please? Then peel on this. Which is a precursor of niacin? Tryptophan. Yes. Good, Himanshu. The precursor of niacin is tryptophan. Very good, Mohammed. Answer this, please. Given picture. So how many times do you see pellagra as being asked? Given picture depicts a deficiency of. So this is Cassell's necklace, which is 3 Ds of pellagra caused by niacin deficiency. Good. So if at all they want to ask you an image-based question on retinol, retinol deficiency, vitamin A deficiency causes white-hot spots, right? Vitamin A deficiency causes white-hot spots. If this image was given to you, then what will be your answer? It is vitamin A deficiency. Good. What if riboflavin was asked? Riboflavin deficiency causes angular stomatitis, right? If they show you lips and on the side, on the angles, if you see lesions like this, then what will be your answer? Your answer would be riboflavin deficiency. Okay. But if they ask you which is the earliest sign, Earliest sign of riboflavin deficiency. What should be our answer? Circumcorneal congestion. Earliest sign of riboflavin deficiency. Can you see that here? Circumcorneal congestion. This is the earliest sign of riboflavin deficiency. This is in full screen, Pratik. If I show it in full screen, you will not be. Can you see it now? Is it enough, Pratik? Which of the following activities? What? I'll tell you about white hot spots. White hot spot, for now, I'm going to tell you about retinol, everything now. Okay? Yes. Which of the following activities are low in riboflavin deficiency? What is your answer? Glutathione reductase. What? It is glutathione reductase. So I am going to tell you about vitamin deficiency and diagnostic tests now. Okay. We are going to fill up this tabular column to learn about deficiency diagnostic tests. Okay. So let's start with thiamine deficiency. Whenever you suspect thiamine deficiency, what will you estimate? You should estimate RBC transketolase activity. Do you understand this? Whenever you suspect thiamine deficiency, what will you ask for? You should ask for RBC transketolase activity. If you suspect riboflavin deficiency, yeah, I'm going to write the full name here, riboflavin deficiency. Don't you know that ribbon and glue go hand in hand? All of you, whenever you do some artwork, ribbon and glue go hand in hand. So riboflavin deficiency, what will you estimate? RBC glue, glutathione reductase activity. Are you clear? Riboflavin deficiency, RBC glutathione reductase activity. First sign, Jati Kumar Sharma. I'm 100% sure. I've read it in all textbooks. The first sign of riboflavin deficiency is circumcorneal congestion. Okay. Yeah, so riboflavin deficiency is RBC glutathione reductase activity. Remember, ribbon and glue. Okay. Next is B6 deficiency. Let me write it as SIX. So tell me what is the last letter in 6? X. So if you suspect B6 deficiency, what will you estimate? X for X. You should estimate xanthurenic acid levels. Yeah, what will you estimate? Xanthurenic acid levels after what load? After tryptophan load. Do you understand this? After X, the alphabet is Y. So you estimate xanthurenic acid levels after tryptophan load. Okay. If you suspect folate deficiency, what is the first letter for folate? F. So if you suspect folate deficiency, what should you estimate? You should estimate FIGLU levels. F for F, folate deficiency, FIGLU levels. In FIGLU, F and G are over. So you estimate FIGLU levels after histidine load. Do you understand this? After histidine load. F, G is over. The next alphabet is H. So FIGLU levels have to be estimated after histidine load. Okay. Now what if you suspect B12 deficiency? If you suspect B12 deficiency, you should estimate methylmalonic acid level. You should estimate methylmalonic acid level after overnight fasting. Do you understand this? After overnight fasting. So can we repeat this, all of you? FIGLU. Formiminoglutamate. FIGLU is formiminoglutamate. Nobody is going to ask you this, okay? So as far as exam preparation is concerned, it has to be a smart work. You exactly have to know what you need to learn and what you don't have to learn. Okay. So of course, all clinical aspects you have to know for sure. Okay. But there are few aspects which you don't have to focus on. For example, FIGLU, nobody is going to ask you what is abbreviation of FIGLU. And if you're interested, I'm more than happy to tell you it is formiminoglutamate. Okay. So can we repeat this? Vitamin deficiency. Look at this table. This PDF will be provided to you after the session, so you don't have to worry about writing down everything. Yeah. So thiamine deficiency, if you suspect, it is RBC transketolase activity. Riboflavin deficiency, ribbon and glue go hand in hand. It is RBC glutathione reductase activity. B6 ends with X. So you estimate xanthurenic acid level in urine after tryptophan load. Folate deficiency, F or F, you estimate FIGLU levels after histidine load. B12 deficiency, you estimate methylmalonic. Yes, you will get the PDF sheet, Shivam. People in Chennai are still celebrating Diwali, and that's why you're hearing cracker noises in the background. So B12 deficiency, you will get the PDF. Okay, so B12 deficiency, estimate methylmalonic acid levels after overnight fasting. Clear? The micronutrient that is deficient following post-ileal resection is. So all micronutrients get absorbed in the proximal small intestine. Is that clear? All micronutrients get absorbed in the proximal small intestine. Only B12 gets absorbed in the terminal ileum. So whenever there is ileal resection, B12 absorption is affected. So post-ileal resection, which vitamin deficiency do you observe? B12. So let me use this chance to tell you all about B12. Please memorize all these facts. The first fact is all sources of vitamin B12 are non-vegetarian sources. So when will you see B12 deficiency? Whenever a person is a pure vegetarian. Veganism can make a person prone to develop B12 deficiency because all natural sources of B12 are non-vegetarian sources. Okay, and there are two coenzyme forms of B12. One is methyl B12. The other one is adenosyl B12. So tell me, what are the two coenzyme forms of B12? Methyl B12 and adenosyl B12. Methyl B12 is necessary as a coenzyme for methionine synthase. Easy to remember, right? Methyl B12 is necessary as a coenzyme for methionine synthase. Adenosyl B12 is necessary as a coenzyme for methylmalonyl-CoA mutase. Adenosyl B12 is necessary as a coenzyme for methylmalonyl-CoA mutase. So have you memorized all these facts? All sources of B12 are non-vegetarian sources. B12, there are two coenzyme forms, just two coenzyme forms. One is methyl B12, the other one is adenosyl B12. Methyl B12 is necessary for methionine synthase. Adenosyl B12 is necessary for methylmalonyl-CoA mutase. Now, what do you expect whenever there is B12 deficiency? Whenever there is B12 deficiency, you should expect neurological manifestations. Do you understand this? What will you estimate? Neurological manifestations wherein they present with peripheral sensory neuropathy that progresses to cause subacute combined degeneration. Right? Very good, Ajas Krantilal Dalvi. Yes, it progresses to present with subacute combined degeneration. And the second manifestation of B12 deficiency is it causes folate deficiency. Whenever there is B12 deficiency, it causes folate deficiency, and folate deficiency causes macrocytic anemia. Do you understand this? Folate deficiency causes macrocytic anemia. If you know these facts, it's more than enough, because I've already told you, whenever you suspect B12 deficiency, what will you estimate in urine? Can anybody answer that, all of you? Yeah, whenever you suspect B12 deficiency, what will you estimate in urine? You have to estimate methylmalonic acid level in urine after an overnight fasting. Okay, so that's all about B12.
Dad.
Can you answer this now? A lactating mother. So I don't know why this is getting cropped. So this is an FMG Jan 2024 MCQ. A lactating mother who follows a strict vegetarian diet presents with fatigue, weakness and numbness in her extremities. So vegetarian person presenting with neurological manifestations. Upon examination, blood work reveals a decreased total iron binding capacity. Okay, which of the following deficiencies can cause this clinical picture? Excellent. What is answer? It is B12 deficiency. How did you exclude iron deficiency? Had it been iron deficiency, total iron binding capacity will be high. Do you understand this? An iron deficiency, total iron binding capacity will be high. Because in this case it is low and the person is a strict vegetarian with neurological manifestations. Then what will be your answer? Your answer would be to vitamin B12 deficiency. Okay. So which of the following deficiencies causes xerophthalmia? Many of you were asking me for vitamin A, right? I was waiting for discussing this MCQ. So which of the following deficiency causes xerophthalmia and follicular hyperkeratosis? What is xerophthalmia due to? Vitamin A deficiency. What is follicular hyperkeratosis? Follicular hyperkeratosis is nothing but phrenoderma. Okay, what is phrenoderma? You will see small papillar lesions in the back of elbow. Okay, so look at this. Can you see that? This is follicular hyperkeratosis when you see small papillar lesions with keratin plug at the tip. Can you see white color plug at the tip? That is why it is called as follicular hyperkeratosis, because you see keratin plug. This is phrenoderma caused by vitamin A deficiency. Okay, so now let me tell you all about vitamin A. What are the three forms of vitamin A? The alcohol form retinol, the aldehyde form retinal, and the acid form retinoic acid. So what are the three forms of vitamin A? Retinol, retinal, and retinoic acid. Now what is the significance of all these three forms? The alcohol form retinol is the form in which vitamin A is absorbed. That is the form in which vitamin A is transported and stored. So what is the significance of the alcohol form retinol? It is a form in which vitamin A is absorbed, transported and stored. And what is the significance of the aldehyde form retinal? Easy to remember. In this name, do you see retina? In retinal, you see retina. And that's a clue that is given to you. This is the form that is present in eye. Aldehyde form is the one that is present in eye. When I say it is present in eye, it is present as rhodopsin. The aldehyde form is present in rhodopsin as Lebensis retinal in the center. So what is retinal? It is Lebensis retinal in the center that is surrounded by opsin. Okay, so that's about retinal. So the last one, retinoic acid. There are two forms of retinoic acid. One is all trans retinoic acid. The other one is 13-cis retinoic acid. Yeah, one is all trans retinoic acid. The other one is 13-cis retinoic acid. Now, what is the significance of 13-cis retinoic acid? This suppresses keratinization of epithelium. Do you all understand this? 13-cis retinoic acid. I'm going to tell you, Ms. Sharif. Good question that is. Good Aditya. I'll tell you both. So 13-cis retinoic acid suppresses keratinization of epithelium. So tell me what will happen whenever there is vitamin A deficiency. Whenever there is vitamin A deficiency, what will not happen? So 13-cis retinoic acid suppresses keratinization of epithelium. And that is what happens whenever there is vitamin A deficiency. There is no suppression of keratinization of epithelium. So what do you expect? When there is no suppression of keratinization of epithelium, everywhere there is keratinization. What will happen when there is keratinization of conjunctival epithelium? Once there is keratinization, epithelium will become dry. And conjunctival epithelium becoming dry is responsible for xerophthalmia. Yeah, conjunctival epithelium becoming dry is responsible for xerophthalmia. And then the keratin debris, excess keratinization, keratin debris is responsible for Bitot spots. So the image that I showed you as Bitot spots, it is nothing but keratin debris. So those triangular foamy lesions that you see in the conjunctival epithelium is nothing but Bitot spots. Do you understand this? That is keratin debris. And not only conjunctiva, even corneal epithelium will undergo dryness, and that causes keratomalacia. Do you understand this? There will be corneal xerosis first. First there is corneal dryness, and that will be followed by corneal softening. And this corneal softening is called as keratomalacia. First cornea undergoes softening, that is followed by corneal ulcer. And this corneal ulcer will be followed by corneal scar, right? And that is why there will be corneal opacity. So every eye manifestation that you see in vitamin A deficiency is because of very low 13-cis retinoic acid, and there is no suppression of keratinization. Everywhere there is excessive keratinization. When conjunctival epithelium undergoes keratinization, that causes conjunctival dryness, that is called as xerophthalmia. Keratin debris is responsible for Bitot spots. Corneal epithelium dryness causes corneal xerosis, that is followed by corneal softening. What is corneal softening? It is keratomalacia. First it becomes soft, then there will be corneal ulcer and corneal opacity. Is that clear, everybody? So that's about 13-cis retinoic acid. And which is the earliest sign? Yeah, which is the earliest sign of vitamin A deficiency? It is delayed dark adaptation time. Earliest sign is delayed dark adaptation time. And which is the earliest symptom? Earliest symptom of vitamin A deficiency is night blindness or nyctalopia. Okay, so that's all about vitamin A. And many of you were asking me what is the difference between phrenoderma and eruptive xanthomas. So what is the difference? Phrenoderma and eruptive xanthomas both are present along the extensor surfaces of the limb. So both will be seen at the back of the elbow. But the difference is in phrenoderma, at the tip of these papillar lesions, what would you see? You will see a small keratin plug. If you don't see this keratin plug, and if you see small papillar lesions alone along the back of the elbow, tiny papillar lesions along the back of the elbow, then that is eruptive xanthomas. If you see phrenoderma, it is because of vitamin A deficiency or because of essential fatty acid deficiency. Whereas eruptive xanthomas, if you see eruptive xanthomas, it means the person has got hypertriglyceridemia. Are you clear, everybody? What are you confused about, Jati Kumar Sharma? First sign is delayed dark adaptation time. Abhishek, I think you were the person who asked, right? To differentiate between, yes. So this is the difference. If you see a small keratin plug at the tip, then that is phrenoderma. If you don't see that, it is eruptive xanthoma. Phrenoderma is because of essential fatty acid deficiency or vitamin A deficiency. Eruptive xanthomas meaning there is hypertriglyceridemia. Okay. A patient with a history of chronic alcoholism is admitted to the hospital with symptoms of confusion, ataxia and ophthalmoplegia. According to PSM, it is conjunctival xerosis. That's the first sign, is it? Okay, probably I'll check and I'll confirm it. Yes, what is the right answer? It is thiamine deficiency. So what you see here is global confusion, right? Global confusion, ophthalmoplegia and ataxia. So the first letters GOVA, right? It's a mnemonic that is given for Wernicke's encephalopathy. Yeah, that's a mnemonic that is given for Wernicke's encephalopathy that is caused by thiamine deficiency. So whenever you learn about thiamine deficiency, please remember it can present as acute thiamine deficiency or as chronic thiamine deficiency. Acute thiamine deficiency is Wernicke's encephalopathy, and the mnemonic that you can use to remember manifestations of Wernicke's encephalopathy is GOVA. So tell me, what does GOVA stand for? Global confusion, ophthalmoplegia and ataxia. And let me now use this opportunity to tell you about two facts. First, I will tell you about thiamine, right? And then I will tell you about alcoholism, because both are repeatedly asked about. Okay, so first about thiamine. What are the thiamine dependent enzymes? There are 4 thiamine dependent enzymes. The first one is pyruvate dehydrogenase complex. And if you want to know what is the function of pyruvate dehydrogenase complex, it is to convert pyruvate into acetyl-CoA. Pyruvate dehydrogenase complex helps in the conversion of pyruvate to acetyl-CoA. From where do you get pyruvate? You get pyruvate from glucose. Right? Whenever you consume glucose, glucose becomes pyruvate, and then PDH complex converts pyruvate into acetyl-CoA. Then acetyl-CoA enters into citric acid cycle. Okay. This is how neurons use glucose. Do you understand this? This is how neurons use glucose. Do you know that the preferred fuel for neuron is glucose? Please remember, the preferred fuel for neuron is glucose, and neurons use glucose aerobically. When glucose becomes pyruvate, pyruvate becomes acetyl-CoA, acetyl-CoA enters into citric acid cycle. Okay, so that's about PDH complex. Second enzyme which is dependent on thiamine is alpha-ketoglutarate dehydrogenase complex. Whenever you write PDH complex in a list, you can close your eye and mention it as alpha-ketoglutarate dehydrogenase. Okay, no problem, Jati Kumar Sharma. No issues at all. Okay, so alpha-ketoglutarate dehydrogenase complex is the next thiamine-dependent enzyme. And the third one is branch-chain keto acid dehydrogenase. Don't you see that all these sound very similar? Pyruvate dehydrogenase, alpha-ketoglutarate dehydrogenase, and branch-chain keto acid dehydrogenase. Have you learned that defect of branch-chain keto acid dehydrogenase causes maple syrup urine disease? Yeah, defect of branch-chain keto acid dehydrogenase causes maple syrup urine disease. Okay, and the last enzyme is trans-ketolase. So all of you please memorize it. What are the 4 thiamine dependent enzymes? Pyruvate dehydrogenase, alpha-ketoglutarate dehydrogenase, branch-chain keto acid dehydrogenase, and trans-ketolase. This is why what happens in thiamine deficiency. Whenever there is thiamine deficiency, pyruvate dehydrogenase complex will not work. So neurons cannot use glucose. When neuronal metabolism gets affected, whenever neurons get affected, it causes dry beriberi. Yeah, whenever neurons get affected, it causes dry beriberi. I am very sure you must have learned even in your school that thiamine deficiency causes beriberi, which presents as either dry beriberi or as wet beriberi. In dry beriberi, CNS will be involved. In wet beriberi, CVS will be involved. Neuronal affection causes dry beriberi. Why should neurons get affected whenever there is thiamine deficiency? Because glucose cannot be used by neurons because PDH complex does not work. Okay. Now, another effect of thiamine deficiency is when pyruvate dehydrogenase complex does not work, pyruvate cannot be converted to acetyl-CoA. Yeah, when thiamine deficiency is observed, pyruvate cannot be converted to acetyl-CoA. So no other go, the accumulated pyruvate becomes lactate. Pyruvate can have 2 fates. One is pyruvate can become acetyl-CoA, the other one is pyruvate can become lactate. In thiamine deficiency, when pyruvate cannot become acetyl-CoA, all pyruvate become lactate. And that causes lactic acidosis in thiamine deficiency. Only because branch-chain keto acid dehydrogenase is dependent on thiamine, whenever you make a diagnosis of maple syrup urine disease, start thiamine supplementation. Do you understand this? Whenever you make a diagnosis of maple syrup urine disease, you start supplementing thiamine. Even when the enzyme is not working, when you give the coenzyme, the enzyme will be supported, the activity will be improved. So tell me, what will you start supplementing a patient of maple syrup urine disease? Thiamine. Okay. Because trans-ketolase is dependent on thiamine, whenever you suspect thiamine deficiency, all of you tell me, whenever you suspect thiamine deficiency, what will you ask for? You will ask for RBC transketolase activity. Are you clear about all these parts? Yeah. So tell me, what are the clinical features that you have learned here? Whenever there is thiamine deficiency, neurons get affected. That is why you see dry beriberi. Whenever there is thiamine deficiency, pyruvate becomes lactate. That is why you see lactic acidosis. Maple syrup urine disease responds to thiamine administration. Whenever you suspect thiamine deficiency, you should ask for RBC transketolase activity. Okay. Let's now learn about alcoholism. So how is alcohol metabolized? Alcohol is RCH2OH that is metabolized by alcohol dehydrogenase to form an aldehyde. Then an aldehyde dehydrogenase converts an aldehyde into an acid. Both these are dehydrogenases. What does a dehydrogenase do? Removes hydrogen from the substrate, gives that hydrogen to its coenzyme. What is its coenzyme? NAD, that becomes NADH. So for every molecule of alcohol that is getting metabolized in your body, you get 2 NADH. So the metabolic status of a chronic alcoholic is of high NADH-NAD ratio. Please memorize it. I'm not saying anything which is not necessary for you. These questions are previous year questions. Did I show you that? Yeah, this is a previous year MCQ, and they also asked you what is the reason for hypoglycemia in a chronic alcoholic. You will not be able to answer such conceptual questions if you don't know these concepts. So please spend some time in understanding these concepts. Okay. So in a chronic alcoholic, what will be high? NADH will be high. When these NADH go through electron transport chain, very good, 5 ATPs is right, Krantidal. So when these NADH go through electron transport chain, they form ATP. So in a chronic alcoholic, there is high ATP-ADP ratio. So that is high NADH and high ATP. And whenever the energy status is high, will the person feel hungry? No. And so the person often skips meals. Yeah. A chronic alcoholic always says, I lack appetite. I don't feel hungry at all. I skip my breakfast. I skip my lunch. I'm just drinking. Okay. So there is always lack of appetite in a chronic alcoholic because of the high energy status. And whenever the person skips meals, essential micronutrients become deficient. It's your meal that provides you with essential micronutrients. Because a person is skipping meals, there will be essential micronutrient deficiencies. Out of all micronutrients, thiamine deficiency is more common in a chronic alcoholic. Do you understand this? So if you're asked, why do you see thiamine deficiency in a chronic alcoholic? You should say that alcohol is a source of empty calorie. Alcohol is a source of empty calorie. It is not 0 calorie, empty calorie meaning excess energy without micronutrients. Okay. And I said whenever there is thiamine deficiency, nerves get affected. Did I tell you? Whenever there is thiamine deficiency, nerves get affected. So that presents in 2 forms. One is acute thiamine deficiency. The other one is chronic thiamine deficiency. And as I said, acute thiamine deficiency is otherwise called as Wernicke's encephalopathy. Okay, acute thiamine deficiency is otherwise called as Wernicke's encephalopathy. And what is the mnemonic I gave for Wernicke's encephalopathy? It is GOVA. What does GOVA stand for? Global confusion. All of you please answer. Can I see some interactive answers here please? Global confusion, ophthalmoplegia and ataxia. And this acute thiamine deficiency or Wernicke's encephalopathy is a reversible condition. Okay. And if the person is not getting treated, the person will end up in, very good, excellent. The person will end up in chronic thiamine deficiency. And in chronic thiamine deficiency, it is otherwise called as Korsakoff syndrome. Okay, acute thiamine deficiency is Wernicke's encephalopathy. Chronic thiamine deficiency is Korsakoff syndrome. And Korsakoff syndrome presents with complete memory loss. So they present with retrograde amnesia. Do you understand this? They present with retrograde amnesia, antrograde amnesia, and they present with confabulation. Because of memory loss, they start filling up the memory gap by fabricating stories. This is called as honest lying. What do you mean by honest lying? The person does not even realize that he or she is lying. They just want to fill up the memory gap, so they start fabricating stories, and that's called as confabulation. Yeah. So these are the features of Korsakoff syndrome, a chronic thiamine deficiency, and this is an irreversible condition. Do you understand this? At this stage, even if you give thiamine, even if the person stops drinking, there will be no reverse. Okay, this is an irreversible stage, which is Korsakoff syndrome. So that's about alcoholism and thiamine deficiency. So it's a very clear answer, right? Global confusion, ophthalmoplegia and ataxia. Your answer would be thiamine deficiency. Now try to answer this question. So July 2024 MCQ. A chronic alcoholic patient who is used to taking arak or local alcohol for the last 25 years. So it's a case of chronic alcoholism, suddenly presented with agitation. This is also an FMG question, right? Suddenly presented with agitation and confusion. What is your answer? Adil says it is A. Misbah Sharif says A. Arzuara says it's A. And many of you are answering it as B, which is a very good sign. Yeah, it's a good batch of students. So agitation and confusion, there were gait abnormalities. On inquiry, the person gave a history of alcohol withdrawal for 3 days. So do you all see this? Alcohol withdrawal is the clue. After alcohol withdrawal, if there is global confusion, agitation, it is delirium tremens. Do you understand this? That is why you should not just have few random phrases in mind and you should not pick up answers. So many, when this question was asked, many chose the answer as thiamine deficiency because they saw confusion, they saw alcohol. They did not read the alcohol withdrawal part. So after alcohol withdrawal, if there is confusion, agitation, tremors, then that is delirium tremens. Okay? So delirium tremens is a feature of alcohol withdrawal. It presents on the 2nd to the 10th day of withdrawal. Yeah, 2nd to the 10th day of withdrawal. And they present with GHN. The mnemonic that you can remember for delirium tremens is GHN. So what does GHN stand for? Global confusion, hallucination and night mass. What do they present with? Global confusion, hallucination and night mass. But they also present with physical manifestations like high blood pressure, high heart rate, high body temperature, tremors, right? So not only psychological features like global confusion, hallucination and night mass, what you would also see is, you will also see tachycardia, hypertension, fever and tremors after alcohol withdrawal, that is delirium tremens. Yes. Yes, Krantilal, I'm happy that you watched my session already. GHN, I remember it as government hospital nurse. Okay. So this is also a very recent question, July 2024 FMG paper. Which of the following substances, I have not seen this question even in INI-CET. Okay, that is why I'm asking all of you to not underestimate FMG preparation. Okay, you have to learn all 19 subjects conceptually. Please don't memorize answers. Please try to understand why and learn. Okay. Yes, the answer is sodium fluoride and potassium dichromate. Alcohol estimation, you cannot use a common anticoagulant like citrate or heparin or EDTA. You should use sodium fluoride and potassium dichromate. Okay. So, answer this question. The additive that is used in the, because they have asked you about the additive for alcohol estimation last time, they can ask you some other additive this time, right? So the additive that is used in the given blood collection tube is, what color cap do you see? Very good, Ragendu, Gopan. Good, Mary. Good, Shiva. Good, Sanjay. Yeah, the answer is silica, all of you. Yeah, the answer is silica. Can you tell me what color cap it is? It's a red cap. For red cap, I have a mnemonic. So the mnemonic, yeah, that's where I'm starting, Rohan. So this is a red top tube. Red top tube, and the mnemonic is RSS, which stands for red, silica, and serum. And silica is a clot activator. Okay. Now, gray top tube, I said G for G. Gray top tube is used for glucose estimation. And in today's INICT, they've asked a question on blood collection tube. I just came to know. So gray top tube, G for G, it is used for glucose estimation, and the additive is sodium fluoride and potassium oxalate. And if you're asking me why should fluoride be added for glucose estimation, because fluoride inhibits enolase of RBCs. Okay, fluoride inhibits enolase of RBCs. The next one is lavender top tube. Okay, and this is an EDTA tube. It has either K2 EDTA or K3 EDTA. Do you understand this? It's either K2 or K3 EDTA tubes. And when will you use this? Whenever you need a whole blood sample. When will you need a whole blood sample? Whenever you have to estimate complete blood count. Right? What do you mean by complete blood count? You have to estimate RBC count, WBC count, and then differential count. In which case you cannot allow the cells to clot. If you allow the blood to clot, then all cells will get blocked in the clot. So to count all these cells, you want a whole blood sample. And that is why you add K2 EDTA and K3 EDTA, wherein you get a plasma sample, you mix it, and then you use it for complete blood count. And it is also used for HbA1c, glycated hemoglobin estimation, wherein the whole cell has to be intact. It should not be clotted. So again, you add an anticoagulant. So whenever you need a whole blood sample, for example, complete blood count, HbA1c estimation, or whenever labile parameters are necessary, right? Labile parameters include parathermone, ACTH, and ammonia. Okay, parathermone, ACTH, ammonia, all these are labile parameters which get degraded in the presence of proteases. So proteases have to be inhibited, for which you add EDTA. So tell me, when will you use? Yes, calcium gets chelated. HbA1c level, excellent Shiva, yes. So for all these purposes, we are going to use lavender top tube. So lavender top tube has K2 or K3 EDTA. It is used for complete blood count, HbA1c, parathermone, ACTH, and ammonia. Okay, and this is a blue top tube. Blue top tube is a citrated tube. Citrated tube meaning it has got 3.2% sodium citrate. C for C, it is used for coagulation assays. What do you mean by coagulation assays? Whenever you have to estimate prothrombin time, activated partial thromboplastin time, or fibrinogen assays. Okay, PT, APTT, fibrinogen assays, factor assays. For all these coagulation assays, it has to be a blue top tube which has 3.2% sodium citrate. Okay, that's a blue top tube. Then green top tube is a heparinized tube. And when will you use a heparinized tube? Whenever you want a quick biochemical analysis. Usually for biochemistry, you want a serum sample. Whenever you need a serum sample, you should collect that sample in a red top tube. So for biochemistry, it is a red top tube. But sometimes biochemical estimations have to be quickly done. For example, TROP-T estimation. In TROP-T estimation, the window period is too short, right? In that case, you cannot collect the blood sample. You cannot be waiting for the clotting to happen, serum to get separated. That becomes a very long time. So for a quicker biochemical analysis, we have to collect it in a heparinized tube. Example, TROP-T. Excellent, Mary. And not only for stat biochemical analysis, even for cytogenetics or molecular diagnostics, right? Whenever DNA has to be extracted or RNA has to be extracted, it has to be a heparinized tube. So when will you use the heparinized tube? Whenever quick biochemical analysis needs to be done, or whenever DNA or RNA has to be extracted. For cytogenetics or for molecular diagnostics, it's a heparinized tube. Okay, the last one is yellow. Okay, this is an yellow top tube. Do you see a gel at the bottom? So what is this tube called as? This tube is called as gel and clot activated tube. Meaning this tube has got a gel in the bottom that is sprayed with a clot activator. Okay, so when will you use this and how will you use this? In this case, you collect a blood sample, then you centrifuge the tube. When you centrifuge the tube, the gel will rise up and it will stand like a mechanical barrier between cells in the bottom and serum on top. So when you collect the blood sample in a gel tube, initially the gel will be in the bottom and the blood sample will be collected on top. When you centrifuge it, the gel will ascend up and the gel will act as a mechanical barrier, and it stands between what will be in the bottom, cells will be in the bottom and serum will be on the top. So this gel acts like a mechanical barrier. Do you understand this? It acts like a mechanical barrier so that even if the cells undergo lysis, it will not contaminate the serum. So when will you use a gel and a clot activated tube? Whenever the sample has to be transported or whenever the sample has to be stored, it has to be a gel and clot activated tube. Very good, Akshay. Very good, Tawfiq. Very good, Abhishek. Very good, Mary. Excellent. Yes. So whenever the sample has to be transported or whenever the sample has to be stored, it has to be a gel and a clot activated tube. Okay. Can we have a quick recap, all of you? I'll show you all tubes again. You're going to tell me the purpose. Okay. So starting from a red top tube. So what is the mnemonic I gave for red top tube? It is RSS. So what is it used for? It is used for all biochemical analysis. What is the additive that is present? It is a silica, which is a clot activator. Very good. Excellent. Now this is gray top tube. Quickly answer. Gray top tube, G for G. Glucose estimation. What does it have? It has sodium fluoride and potassium oxalate. Good. The next one. Tell me, lavender top tube. What do you use lavender top tube for? Pathology, complete blood count. What is the additive that is present here? The additive that is present here is K2-EDTA or K3-EDTA. Good. And this is used for complete blood count, HbA1c estimation, labile parameters like parathormone, ACTH and ammonia. This is a blue top tube, which is a citrated tube. It has 3.2% sodium citrate, which is used for coagulation assays. It is used for PT, APTT, fibrinogen and factor assays. Okay. And this is a green top tube, which is a heparinized tube. When will you use a heparinized tube? Whenever a quicker biochemical analysis has to be done. Right, STAT biochemical analysis for TROP-T estimation is an example. Or whenever DNA or RNA needs to be extracted, it has to be a green top tube or a heparinized tube. Good. And then this is the last one, yellow top tube. This is a gel and clot activated tube. This is used whenever the sample for biochemistry. Yeah, whenever the sample for biochemistry has to be stored or has to be transported. And what was the question that was asked in INI-CET today? Just today, the question was the tube that is used for electrolyte estimation is. Choices given were yellow top tube, green, right? Choices were yellow, green, lavender and grey. So tell me, what will you use for electrolyte estimation? You're not supposed to use a grey top tube. You should ask me why. Why should you not use a grey top tube? Because it has got sodium fluoride and potassium oxalate. If you use this tube for electrolyte estimation, sodium values and potassium values will be falsely elevated. You're not supposed to use the lavender top tube because it has got K2-EDTA. Again, potassium will be falsely high. Okay. You're not supposed to use a green top tube because green top tube can have sodium heparin. If it's sodium heparin, sodium values will be falsely elevated. So what is necessary? Yellow top tube, because the gel will come and act like a mechanical barrier, does not allow anything to contaminate the serum so that electrolytes can be estimated in the serum. Okay. So just today, fresh question this is. Answer this please. You know the answer now. A 50-year-old man who is a chronic alcoholic was presented with complaints of confusion, tingling sensation, neurological manifestation is thiamine deficiency. His history revealed polished rice as his main diet. Rice polishing will remove thiamine, right? Polishing rice removes allurin layer. Allurin layer is rich in thiamine, so that causes thiamine deficiency, and very, very good. The next one, the patient had a history of strenuous exercise but forgot to take his meal and later had alcohol in a party. Which of the following processes is inhibited by alcohol? Can you tell me the answer? Alcohol causes hypoglycemia. Do you understand this? Alcohol causes hypoglycemia. So can you tell me why should it cause hypoglycemia? Because alcohol inhibits gluconeogenesis. How does it inhibit gluconeogenesis? Because as I said, whenever a person intakes alcohol, there is high NADH-NAD ratio. Whenever there is high NADH-NAD ratio, all pyruvate become lactate. High NADH will drive the equilibrium between pyruvate and lactate to lactate formation. So there will be low lactate. And high NADH will allow all oxaloacetate to become malate. So oxaloacetate level will also be low. Pyruvate and oxaloacetate are the first two intermediates of gluconeogenesis. When the first two intermediates of gluconeogenesis are missing, gluconeogenesis will be impaired. Whenever gluconeogenesis is impaired, plasma glucose decreases. And that is why a chronic alcoholic is prone to develop repeated episodes of hypoglycemia. So please answer, why does a chronic alcoholic present with hypoglycemia? Because of high NADH-NAD ratio inhibiting gluconeogenesis. Okay. This is again a July 2024 MCQ. Menkes disease is caused by. Can anybody answer this? A very simple question. Copper deficiency causes Menkes disease. Copper toxicity causes Wilson's disease. Are you clear? For copper deficiency causes Menkes disease. Copper toxicity causes Wilson's disease. And Menkes disease is caused by the defect of ATP7A. Wilson's disease is caused by the defect of ATP7B. Okay, so again, Menkes and Wilson's are often asked in FMG. Let me give you an overview on all these two disorders. First, look at this image. Okay, so this image tells you the function of ATP7A. So what is the function of ATP7A? It helps in absorbing copper from intestine so that it can reach the liver. Now, what is the function of ATP7B? 7B has got two functions. One is it helps in allowing copper to get excreted in the bile. After copper is absorbed along the intestine reaches the liver, there are two fates for copper. One is excess copper gets excreted through bile, or the copper gets incorporated into ceruloplasmin. Okay, so incorporation of copper into ceruloplasmin and secretion of copper into bile, both these are through a common transporter. Yeah, both these are through a common transporter, which is ATP7B. And as I told you, 7A defect causes Menkes disease. So what do you expect in Menkes disease, all of you? Copper is not absorbed along the intestine. So there will be copper deficiency. What happens whenever there is copper deficiency? Copper cannot get incorporated into ceruloplasmin. So copper will not reach enzymes. What are the copper-dependent enzymes? Copper-dependent enzymes can be remembered as LCM. What does LCM stand for? First, L stands for lysyl oxidase. One copper-dependent enzyme is lysyl oxidase, which I told you is related to collagen maturation. C stands for ceruloplasmin, right? C stands for ceruloplasmin. M, remember it is melanin. Which is the copper dependent enzyme which helps in melanin formation? It is tyrosinase. So tell me, what are the copper dependent enzymes? One more are Devyani. Yeah, will you be able to cope up with that? It will be an interesting session. Stay put. So what are the copper dependent enzymes? The first copper dependent enzyme is lysyl oxidase. The second one is ceruloplasmin. The third one is melanin synthesizing enzyme, which is tyrosinase. So in Menkes disease, when there is copper deficiency, lysyl oxidase will be inactive. Collagen maturation is bad. And that is why it presents with kinky hair. Right? Kinky hair and fractures. Do you understand this? So that's all about Menkes disease. So tell me, what about Menkes disease? It's caused by the defect of ATP7A, which is responsible for, thank you Devyani, I'm happy. So this is responsible for copper absorption along the intestine. When there is no copper absorption along the intestine, there will be copper deficiency. So copper dependent enzymes, namely lysyl oxidase, ceruloplasmin and tyrosinase will be defective. So that causes kinky hair and fractures. Now what if ATP7B is defective? When 7B is defective, copper cannot be excreted through bile. That causes copper toxicity. And this copper toxicity affects liver and the lenticular nucleus. Right? It affects liver and lenticular nucleus. And that is why it is called as hepatolenticular degeneration. Right? Wilson's disease is otherwise called as hepatolenticular degeneration because of copper toxicity affecting liver and the lenticular nucleus. And on the other hand, because ATP7B is defective, copper cannot be incorporated into ceruloplasmin. This causes two effects. Only after ceruloplasmin accepts copper, ceruloplasmin is stabilized. In this case, ceruloplasmin is not getting stabilized. So there will be low ceruloplasmin levels. So the low ceruloplasmin level that you observe in Wilson's disease is an effect of Wilson's disease, wherein ceruloplasmin stability is lost. So tell me, one of the biochemical features of Wilson's disease is low levels of ceruloplasmin, wherein serum ceruloplasmin levels will be less than 0.2 gram per liter. And only after copper gets attached to ceruloplasmin, copper will not be filtered in the glomerulus. In this case, because copper is not entering into ceruloplasmin, all copper will be lost in the urine. So urinary copper levels will be high. Do you understand this? And in this case, urinary copper level will be high. And what is the diagnostic investigation? The gold standard diagnostic investigation for Wilson's disease is liver biopsy reveals copper accumulation, wherein copper levels will be more than 250 microgram per gram of tissue. So tell me, which is the gold standard test for Wilson's disease? Liver biopsy reveals copper concentration to be higher than 250 microgram per gram of tissue. So tell me, what are the diagnostic investigation for Wilson's disease? One is ceruloplasmin is not stabilized. So ceruloplasmin levels less than 0.2 gram per liter. When it is not attached to ceruloplasmin, it will be filtered along the glomeruli. So urinary copper level will be more than 100. Yeah, it will be more than 100 microgram per 24 hours. And the gold standard diagnostic investigation for Wilson's disease is, what did I tell you? Liver biopsy reveals copper concentration to be more than 250 microgram per gram of tissue. So that's about Wilson's disease, which is hepatolenticular degeneration. And Wilson's disease is characterized by sunflower cataract. Apart from liver getting affected, apart from lenticular nucleus getting affected, it's characterized by sunflower cataract. Okay. So which of the following enzymes is found to be deficient in von Buerk's disease? So glycogen storage disorder is a favorite topic for FMG. I want all of you to listen to this session carefully for the next 15 minutes. In 15 minutes, we'll be learning about the entire glycogen storage disorder, and you will be able to answer any MCQ on this topic. That is my assurance. Okay, so von Giochi's disease is type 1 glycogen storage disorder. 1 stands for von, right? Von Giochi's disease type 1 glycogen storage disorder, wherein the enzyme that is defective is glucose 6-phosphatase. Yeah, which enzyme is defective? Glucose 6-phosphatase is defective. And what is the significance of glucose 6-phosphatase? It's an enzyme of glycogenolysis and gluconeogenesis. Very good, Mohammed Ahmed. One is one. So glucose 6-phosphatase is an enzyme that is common to both glycogenolysis and gluconeogenesis. There are just two pathways in your body which can maintain blood glucose. Those two pathways are glycogenolysis and gluconeogenesis. And then von Giochi's disease, both these pathways are defective. So there is no way blood glucose can be maintained. So what does it present as? It presents as severe fasting hypoglycemia. Whenever you have your food, the diet will maintain plasma glucose. When you don't have your food, glycogenolysis and gluconeogenesis should maintain blood glucose. In von Giochi's disease, both glycogenolysis and gluconeogenesis are not active. So the moment you start fasting, there will be hypoglycemia. That's about glucose 6-phosphatase defect, which presents as severe fasting hypoglycemia. Let's learn about other choices. Branching enzyme defect. Branching enzyme starts with B. What is the letter before B in alphabet? A. So branching enzyme defect is causes A stands for Anderson's disease. Do you understand this? Branching enzyme defect causes Anderson's disease. And Anderson's disease, if there is no branching enzyme, glycogen will not be compact. The function of branching enzyme is to provide compactness to glycogen. When there is branching enzyme defect, glycogen will not be compact. So a non-compact glycogen accumulates in liver, causing liver enlargement. So Anderson's disease will present as hepatomegaly and as liver cirrhosis. Do you understand this? Anderson's disease will present as hepatomegaly and as liver cirrhosis, because in this case a non-compact glycogen accumulates in liver. Very good. Now D branching enzyme defect. What is the first alphabet here? T. Tell me the alphabet before D. It is C. So D branching enzyme defect causes Cory's disease. Branching enzyme defect causes Anderson's disease. D branching enzyme defect causes Cory's disease. In this case, D branching enzyme is defective in both liver and in muscle. So in both liver and muscle, glycogenolysis does not happen. When liver glycogenolysis does not happen, that causes hypoglycemia. When muscle glycogenolysis does not happen, muscle becomes weaker. So that causes exercise intolerance. So tell me, what do you see in Cory's disease or D branching enzyme defect? It's a defect of D branching enzyme in both liver and muscle. So it causes both hypoglycemia and exercise intolerance. Okay. Myophosphorylase defect starts with M. It causes M again. Myophosphorylase defect causes McArdle's disease. And when muscle phosphorylase is defective, muscle becomes weaker and that causes exercise intolerance. Do you understand this? So if you want to understand all about glycogen storage disorders, there are few facts that you need to know. Glycogen is stored in liver and in muscle. Please repeat this along with me. Glycogen is stored in liver and in muscle. Whenever liver glycogen is affected, it causes hypoglycemia. Whenever muscle glycogen metabolism is affected, it causes exercise intolerance. Whenever both liver glycogen metabolism and muscle glycogen metabolism are affected, it will cause both hypoglycemia and exercise intolerance. Do you understand the outline? As far as glycogen storage disorders are concerned, you should remember glycogen is stored in liver and muscle. Liver glycogen metabolism defect causes hypoglycemia. Muscle glycogen metabolism defect causes exercise intolerance. When both are defective, it causes both hypoglycemia and exercise intolerance. Okay, let's first fill up this table to learn all 8 glycogen storage disorders, their enzyme defects, and then I will tell you the classification. I said 8 glycogen storage disorders, but I've shown you only 7 Roman letters. So what is type 0? Type 0 is glycogen synthase deficiency. Do you understand this? Type 0 is glycogen synthase deficiency, wherein the enzyme that is defective is glycogen synthase. Now do you understand why it's called as type 0? Because it's a glycogen storage disorder without glycogen storage. When glycogen synthase is defective, glycogen is not stored at all. So it's a glycogen storage disorder without any glycogen storage. That's why it's called as type 0. Okay. Type 1. Can you all start answering? Type 1 stands for Vaughan. So 1 is Vaughan-Jaques disease, wherein the enzyme that is defective is glucose 6-phosphatase. Okay. Why is it called as type 1? Because as I told you, when glucose 6-phosphatase is defective, it presents as severe fasting hypoglycemia. Anything which is severe will be presented first. The first glycogen storage disorder to be identified by clinicians was Vaughan-Jaques disease. That is why it's called as type 1, because it presents as severe fasting hypoglycemia. Okay. Type 2, Pompe's disease. Type 2 is Pompe's disease, wherein the enzyme that is defective is acid maltase. The enzyme that is defective is acid maltase or alpha glucosidase. It is acid maltase or alpha glucosidase defect which causes Pompe's disease. Okay. Type 3, which is the third alphabet, C. Alphabetical order, the third alphabet is C. So type 3 is C. C stands for Cory's disease. C has to be followed by D. So Cory's disease is caused by the defect of D branching enzyme. You understand this? Cory's disease is caused by the defect of D branching enzyme. C and D are over. So now it is A and B. Type 4 is Anderson's disease. Okay, type 4 is Anderson's disease caused by the defect of branching enzyme. Now it is type 5. Roman letter 5 looks like the letter V. So invert it, write it twice. Okay, invert it and write it twice. It is M. So type 5, M stands for McArdle's disease. M for M, McArdle's disease is caused by the defect of muscle phosphorylase. Okay, so type 5 is McArdle's disease, muscle phosphorylase defect. Type 6, Hirsch's disease, H for H, hepatic phosphorylase defect. Hirsch's disease is hepatic phosphorylase defect. Type 7, Tarrow's disease. Type 7, you write it like this, right? 7 is Tarrow's disease. Tarrow's disease is caused by the defect of phosphofructokinase 1. Okay, Tarrow's disease is caused by the defect of phosphofructokinase 1. So are you clear about 8 glycogen storage disorders? Can you repeat this? What is type 0? Type 0 is glycogen synthase deficiency. What is the doubt? I think I missed that. I'm not able to go up also. Somebody had a big doubt. No, yeah. Okay, it's an answer. So type 0 is glycogen synthase deficiency. Type 1 is Vaughan-Jaques disease. Type 2 is Pompe's disease, acid maltase or alpha glucosidase defect. Type 3, Cory's disease, D branching enzyme defect. Type 4, Anderson's branching enzyme defect. Type 5, McArdle's disease, muscle phosphorylase defect. Type 6, Hirsch's disease, hepatic phosphorylase defect. Type 7, Tarrow's disease, phosphofructokinase 1 defect. Okay, so that's all about the names and the disorders. Answer this question. 8-month-old infant presents with fasting hypoglycemia. On examination, hepatomegaly was observed. Blood investigation revealed lactic acidosis, ketosis, and xanthomas. What is the most probable enzyme deficiency? Whenever you're given a case-based question, do not jump to an answer. Okay? Try to exclude choices one by one. Okay? Can it be a branching enzyme defect? Answer is no. Because branching enzyme defect, I told you, is Anderson's disease. When branching enzyme is defective and non-compact glycogen accumulates, that causes hepatomegaly and cirrhosis. I did not say hypoglycemia for Anderson's disease. Can it be glycogen synthase deficiency? I said glycogen synthase deficiency is type 0. In type 0, both in liver and in muscle, glycogen is not synthesized. When liver glycogen is not synthesized, yes, it will cause hypoglycemia. When muscle glycogen is not synthesized, it causes exercise intolerance. So glycogen synthase deficiency will present with both hypoglycemia and exercise intolerance. But have they mentioned anything about exercise intolerance in the history? No. And that is why it is not glycogen synthase deficiency. Okay. Acid maltase defect. Acid maltase defect is Pompey's disease. I want you to know that Pompey's disease is the only glycogen storage disorder which is also a lysosomal storage disorder. Is it lagging again? So Pompey's disease is the only glycogen storage disorder which is also a lysosomal storage disorder. And what does it present as? In Pompey's, the pump gets affected. Can you remember it that way? In Pompey's, the pump gets affected. Which is the pump of your body? Heart. So in Pompey's, heart gets affected. It presents as cardiomegaly, cardiomyopathy. Okay, it presents as cardiomegaly, cardiomyopathy. Along with that, it also presents with hypotonia. Yeah, it also presents with hypotonia. So it will present itself as floppy baby. You understand this? It will present itself as floppy baby. So all of you repeat it along with me. Pompey's disease is the only glycogen storage disorder which is also a lysosomal storage disorder caused by the defect of acid maltase or alpha glucosidase. The pump is affected. It presents as cardiomegaly, cardiomyopathy. It also presents with hypotonia and floppy baby. Do you see any cardiomegaly or cardiomyopathy in the history that is provided to you? So it is not acid maltase defect. So tell me what is the right answer here. The right answer here is glucose 6-phosphatase defect. And we know this is the condition that presents as severe fasting hypoglycemia. So this is an FMG June 2021 question. So even in June 2021, they have started asking you such complex case-based MCQ. So for you people, when you go and attempt your 2024 exam, right, you have to be very clear about all these concepts. Got it? So I'm going to tell you about classification of glycogen storage disorders. Okay, classification of glycogen storage disorders. Glycogen storage disorders can be classified into 4 types. What are the 4 types? The first category presents with fasting hypoglycemia. The second category presents with exercise intolerance. Third category presents with both fasting hypoglycemia and exercise intolerance. The last category presents with neither fasting hypoglycemia nor exercise intolerance. Can you repeat this along with me, all of you? Please keep the chat box active. So tell me, what are the 4 categories of glycogen storage disorders? Those which present with fasting hypoglycemia, those which present with exercise intolerance, those which present with both neither fasting hypoglycemia nor exercise intolerance. Okay. In the first category, with fasting hypoglycemia, what are the disorders? Type 0, type 1, type 3 and type 6. So tell me, what are the conditions which present with fasting hypoglycemia? Type 0, type 1, type 3 and type 6. Please memorize these 4 numbers. Okay, 0, 1, 3 and 6. Exercise intolerance is again 0 and then odd numbers. What are the odd numbers? 3, 5 and 7. Exercise intolerance will be 0, 3, 5 and 7. Now you tell me both. Where do you see both? Type 0 and type 3. So both type 0 and type 3 present with both fasting hypoglycemia and exercise intolerance. Now the last one, neither fasting hypoglycemia nor exercise intolerance will include type 2 and type 4. Okay, neither fasting hypoglycemia nor exercise intolerance will include type 2 and type 4. So this is how you classify glycogen storage disorders. Now let's start with the first category, those which present with fasting hypoglycemia. Can you tell me the names? The numbers first. What are the types? Type 0, 0, 1, 3 and 6. Okay, tell me their names. What is type 0? Glycogen synthase deficiency. All of you please be active. Type 1. What is type 1? Von Yerkes disease. What is type 3? Cory's disease. What is type 6? Hirsch disease. Okay, so this is about the types and the names. Let's now discuss features. Glycogen synthase deficiency. I have not mentioned whether it is liver or as muscle, which means it is defective both in liver and in muscle. What will happen when both liver and muscle glycogen are affected? It will present as both fasting hypoglycemia and as exercise intolerance. Right? It will present as both fasting hypoglycemia and exercise intolerance. Whenever you see both in a child, you should ask for liver biopsy. Wherever you see a child presenting with both fasting hypoglycemia and exercise intolerance, you ask for liver biopsy. In glycogen synthase deficiency, liver biopsy reveals 0 glycogen in liver. That is why it is type Z. No. So that's about glycogen synthase deficiency. Okay. Now von Yerkes disease, which is glucose 6-phosphatase defect, which is a defect of both glycogenolysis and gluconeogenesis. When both these pathways are defective, as I said, it will present as severe fasting hypoglycemia. Right? What will it present as? Severe fasting hypoglycemia, which does not respond to counter-regulatory hormone administration. So there are so many causes of fasting hypoglycemia, but the one way by which you can differentiate von Yerkes disease from other glycogen storage disorders is all other glycogen storage disorders which present with hypoglycemia will respond to a counter-regulatory hormone administration. What do you mean by counter-regulatory hormone? You administer glucagon, you administer growth hormone. You will see that the hypoglycemia will be circumvented and the plasma glucose becomes normal. But if it's von Yerkes disease, it will present a severe fasting hypoglycemia which does not respond to counter-regulatory hormone administration. Is that clear? So that's about von Wieck's disease. Why will it not respond to counter-regulatory hormone administration? Because in this case, both glycogenolysis and gluconeogenesis are defective. These are the two pathways which can maintain blood glucose. When both the pathways are defective, your counter-regulatory hormones cannot do anything. So von Wieck's disease will present a severe fasting hypoglycemia which does not respond to counter-regulatory hormone administration. Okay. Now Cory's disease or debranching enzyme defect. Again, I have not mentioned whether it is liver debranching enzyme or muscle debranching enzyme, which means it's defective both in liver and in muscle. When liver glycogen metabolism is affected, it will present as fasting hypoglycemia. When muscle glycogen metabolism is affected, it will present as exercise intolerance. So not only type 0, even in type 3, you find both hypoglycemia and exercise intolerance. And I told you, whenever you see both hypoglycemia and exercise intolerance, you should take liver biopsy. In this condition, when you take liver biopsy, because it's a defect of only debranching enzyme, only branch points will not be removed. So there will be an abnormal glycogen that accumulates in this condition. In this abnormal glycogen, you will see multiple branch points. In this abnormal glycogen, you will see multiple branch points. And that is called as limit dextrin. So on liver biopsy, if you see limit dextrin, then that is called as Cory's disease or limit dextrinosis. So tell me, how will you differentiate type 0 and type 3? Clinically, both type 0 and type 3 present with both fasting hypoglycemia and exercise intolerance. You can differentiate the two by liver biopsy. If liver biopsy reveals 0 glycogen, it is type 0. If liver biopsy reveals limit dextrin, it is Cory's disease or limit dextrinosis. Okay. Hurst's disease. Hepatic phosphorylase defect. Whenever there is liver phosphorylase or hepatic phosphorylase defect, what will you see? Hypoglycemia. So Hurst's disease will also present as fasting hypoglycemia. But will it be as severe as von Wieck's? No. This will be mild to moderate because Hurst's disease is only a defect of glycogenolysis. It's a defect of liver glycogen phosphorylase. It's a defect of only glycogenolysis. But gluconeogenesis is intact. So that can maintain blood glucose. So this will not be a severe fasting hypoglycemia. This will be a mild to moderate fasting hypoglycemia which responds to counter-regulatory hormone administration. So whenever the history says severe fasting hypoglycemia which does not respond to counter-regulatory hormone, it is von Wieck's disease. Mild to moderate fasting hypoglycemia which responds to counter-regulatory hormone administration is Hurst's disease. Got it? So if you ask me for an algorithm, whenever there is fasting hypoglycemia, the history says there is a child presenting with fasting hypoglycemia. How will you make a diagnosis? Step number 1, find out if there is exercise intolerance also. So what if there is exercise intolerance as well? Then you take liver biopsy. I said whenever there is fasting hypoglycemia and exercise intolerance, you should take liver biopsy. If liver biopsy reveals 0 glycogen, can you tell me what is your diagnosis, all of you? If liver biopsy reveals 0 glycogen, it is type 0 or glycogen synthase defect. If liver biopsy reveals limit dextrin, what is your diagnosis? It is type 3 or Cory's disease or limit dextrinosis. Okay. What if there is no exercise intolerance, only fasting hypoglycemia? If it's only fasting hypoglycemia, check for response to counter-regulatory hormone administration. If there is no response, please tell me what is the answer when there is no response to counter-regulatory hormone administration. It is von Yerkes disease. When there is response to counter-regulatory hormone administration, then what is it? It is Hers disease. Is it not simple, all of you? Yes? Have you all understood this algorithm? Yeah, so this is how conceptually you have to understand before exam so that you're able to answer it irrespective of the history that is given to you. Okay, good. So now about exercise intolerance. So tell me, what are the disorders which present with exercise intolerance? I said 0 and odd numbers. 0, 3, 5 and 7. Okay, so can you tell me the names? It's just a repetition. Tell me the names. Type 0 is glycogen synthase deficiency. Type 3, Cory's disease. Type 5, McArdle's disease. Type 7, Taruv's disease. Okay? Because you know these facts, you will know the features. Can you start telling me what will you see in the first two? Type 0 and type 3 we have already discussed. Glycogen synthase deficiency or type 0 present with both fasting hypoglycemia and exercise intolerance. Liver biopsy reveals 0 glycogen. Cory's disease, hypoglycemia and exercise intolerance. Liver biopsy reveals branched glycogen or limit dextrin. Right? Now McArdle's disease or muscle phosphorylase defect. It's only a defect of muscle phosphorylase. So what will you see? You will see only exercise intolerance. No other features, just exercise intolerance. That is McArdle's disease. Okay? Taruv's disease. Phosphofructokinase 1 is defective. So which pathway is defective? Glycolysis is defective. Whenever there is glycolytic enzyme defect, any cell which is dependent on glycolysis will be affected. So for which cell is glycolysis indispensable? For RBCs. So whenever there is a glycolytic enzyme defect, both RBCs and white muscle fibers get affected. When RBCs get affected, it will present as hemolytic anemia. Okay, when white muscle fibers get affected, it will present as exercise intolerance. So tell me, what will you see in Taruv's disease? In Taruv's disease, you will see exercise intolerance and hemolytic anemia. Got it? So that's about the 4 disorders which present with exercise intolerance. So what are the 4 disorders? 0, 3, 5 and 7. So what is the mental algorithm that you will have for exercise intolerance? Whenever a mother brings a child with history of exercise intolerance, what you're supposed to do is, you're supposed to get a fasting blood sample. And in that fasting blood sample, you estimate glucose and LDH. Right? Whenever there is a child with exercise intolerance, collect fasting sample and you estimate glucose and LDH. What if there is fasting hypoglycemia? Can you all answer? Exercise intolerance and fasting hypoglycemia. What will you do? Take a liver biopsy. If liver biopsy reveals 0 glycogen, it is type 0. If liver biopsy reveals limit dextrin, it is type 3. This we know already. What if the plasma glucose in the fasting state is normal? If the plasma glucose in the fasting state is normal, then you check LDH. What if LDH levels are high? If LDH level is high, it's a sign of hemolysis. So exercise intolerance with hemolytic anemia. Do you understand this? Exercise intolerance with hemolytic anemia is glycolytic enzyme defect. That is glycolytic enzyme defect. What if LDH levels are also normal? There is only exercise intolerance. In that case, it is type 5. Got it? In that case, it is type 5. So this is the algorithm for exercise intolerance. Finally, neither fasting hypoglycemia nor exercise intolerance, that is type 2 and type 4. Right? Type 2 and type 4. What is type 2? Lysosomal storage disorder, which presents with cardiomegaly and cardiomyopathy. It presents with hypotonia. So the diagnosis will be straightforward. The moment you see cardiomegaly, cardiomyopathy, hypotonia, you know it is Pompey's disease. Type 4 or Anderson's disease will present as hepatomegaly and liver cirrhosis. So are you all now confident in answering any glycogen storage disorder? If you're confident, can I see a thumbs up, please?
That's good.
That's all. Others? Very good. So now, let's learn one more case-based MCQ, because they ask you often about porphyrias, right? Thanks all of you. I'm very happy that many of you have understood it. Try to read this. A 35-year-old man has a history of intermittent abdominal pain and episodes of confusion and psychiatric problems. Very good, Kranti Lal. Very good, Anshul. Good, Rohan. Good, Devik. No, Devyani has answered it as porphyria cutanea tarda. If it was porphyria cutanea tarda, the name by itself tells you that skin should be affected and there should be photosensitivity. Have they given you anything about photosensitivity in the history? They have not told you about itching. They have not told you about burning sensation, blister formation, atrophic scarring, no skin manifestation. The moment you see that there is no skin manifestation, please exclude porphyria cutanea tarda. Okay, so what is the answer here? The answer here is acute intermittent porphyria. Why am I saying it is acute intermittent porphyria? Because it's a porphyria that is presenting with neuropsychiatric manifestations. Why am I saying neuro? Intermittent abdominal pain, meaning sensory neuropathy, psychiatric problems. So this is a person presenting with neuropsychiatric manifestations without photosensitivity. Okay? Whenever you see only neuropsychiatric manifestations without photosensitivity, you should estimate ALA and PBG. If both ALA and PBG are elevated, it is called as the most popular acute intermittent porphyria. Acute intermittent porphyria is caused by the defect of uroporphyrinogen 1 synthase. Okay, acute intermittent porphyria is caused by the defect of uroporphyrinogen 1 synthase. So let me repeat this. For you to make a diagnosis of porphyria as acute intermittent porphyria, there should be neuropsychiatric manifestations without photosensitivity with elevation of both ALA and PBG. Okay, now if you learn about acute intermittent porphyria alone, it is not enough. If this time they ask you about acute intermittent porphyria, they may ask you about anything else in the future, right? So let's learn about all types of porphyrias, for which first I'm going to tell you the names of the disorders. Okay, let's memorize names of the disorders first, and then we'll learn about the features. Okay, so what if ALA synthase is defective? When ALA synthase is defective, it's a complete defect. So what will not be synthesized? Heme will not be synthesized. When heme is not synthesized, it causes anemia. So ALA synthase 2 defect, yeah, ALA synthase 2 defect causes anemia. Which anemia is it? X-linked sideroblastic anemia. Do you understand this? What will it cause? It will cause X-linked sideroblastic anemia. Next one. When ALA dehydratase is defective, when ALA dehydratase is defective, can we call it as ALA dehydratase defective porphyria? Logical name, right? What will you call it as? You will call it as ALA dehydratase defective porphyria. Okay. Next. Then uroporphyrinogen 1 synthase is defective. That is called as acute intermittent porphyria. Yeah, that's called as acute intermittent porphyria. And how will you differentiate ALA dehydratase defective porphyria and acute intermittent porphyria? In ALA dehydratase defective porphyria, what alone will be elevated? ALA alone will be elevated. Whereas in acute intermittent porphyria, both ALA and PBG will be accumulated. This is how you differentiate ALA dehydratase defective porphyria and acute intermittent porphyria. Clear? Now, uroporphyrinogen 3 synthase defect. 3 and E sound similar. Am I right? 3 and E sound similar. So, 3 synthase defect causes E. What does E stand for? Congenital erythropoietic porphyria. 3 defect causes E. What is E? Congenital erythropoietic porphyria, which is the most severe of photosensitivity porphyrias. Have you all read about vampires? If yes, can I see? Yes, Sanjay. Very good. Have you all heard about vampires? Right? Vampires with nocturnal behavior, right? With the atrophic scarring and erythrodontia, meaning red fluorescence of teeth, right? So that vampire disease is congenital erythropoietic porphyria, which is the most severe of photosensitivity porphyrias, which means congenital erythropoietic porphyria presents with only photosensitivity, no neuropsychiatric manifestations. Okay. The next one is uroporphyrinogen. Yes, twilight saga. You're right. Yes, Shadab Allah. So uroporphyrinogen decarboxylase defect. In decarboxylase, you see a C. So defect causes C. What C is it? Porphyria cutanea tarda. Okay, uroporphyrinogen decarboxylase defect causes Porphyria cutanea tarda. Decarboxylase has a C. The disorder's name also has got a C. It is Porphyria cutanea tarda. When coproporphyrinogen oxidase is defective, it causes hereditary coproporphyria. Okay, when coproporphyrinogen oxidase is defective, it is called as hereditary coproporphyria. Very good, Tawfiq Ahmed. Yes, Porphyria cutanea tarda is the most common. Which is the most common porphyria? It is Porphyria cutanea tarda. When coproporphyrinogen oxidase is defective, logically what will you call it as? Hereditary coproporphyria. When protoporphyrinogen oxidase is defective, do you see various P's in the name? Protoporphyrinogen oxidase. In the name you see various P's. Defect causes variegate porphyria. Okay, defect causes variegate porphyria. defect causes variegate porphyria. Finally, ferrochelatase defect. Ferrochelatase defect causes erythropoietic protoporphyria. The last defect, ferrochelatase defect, causes erythropoietic protoporphyria. So I am going to repeat all these names with your help. I want all of you to repeat it along with me. Okay. So tell me, what if ALA synthase 2 is defective? When ALA synthase 2 is defective, it is called as X-linked sideroblastic anemia. ALA dehydratase defect causes ALA dehydratase defective porphyria. Okay, ADP. Uroporphyrinogen 1 synthase defect causes acute intermittent porphyria. Uroporphyrinogen 3 synthase defect. 3 and E sound similar. So 3 synthase defect causes congenital erythropoietic porphyria. Uroporphyrinogen decarboxylase defect causes porphyria cutanea tarda. Coproporphyrinogen oxidase defect causes, all of you answer, coproporphyrinogen oxidase defect causes hereditary coproporphyria. Protoporphyrinogen oxidase defect causes variegate porphyria. Ferrochelatase defect causes erythropoietic protoporphyria. Okay, so these are the names. Are you clear about the names? Yeah. So now about classification of porphyrias. So how do we classify porphyrias? You classify porphyrias into 3 categories. The first category presents with only neuropsychiatric manifestations. Second category presents with only photosensitivity. Third category presents with both. Do you understand this? So tell me, what are the 3 types of porphyrias? Those which present with neuropsychiatric manifestations, those which present with photosensitivity, those which present with both. Okay. So what are the 2 disorders which come under the first category? The first 2 disorders. Tell me, what are the first 2 porphyrias I told you about? ALA dehydratase defective porphyria and acute intermittent porphyria. So tell me, what are the 2 porphyrias present with only neuropsychiatric manifestations? ALA dehydratase defective porphyria and acute intermittent porphyria. And how will you differentiate these 2? If only ALA is high, it is ALA dehydratase defective porphyria. Then both ALA and PBG are elevated. Both ALA and PBG are elevated, that is acute intermittent porphyria. Clear? So first category with neuropsychiatric manifestations, it is ALA dehydratase defective porphyria and acute intermittent porphyria. There are 3 disorders which come under the second category with only photosensitivity. The first one is the vampire disease. Tell me, which is the vampire disease? Congenital erythropoietic porphyria, which is the most severe. And then porphyria cutanea tarda, which is the most common. And the last one, erythropoietic protoporphyria. So tell me, what are the 3 porphyrias which present with photosensitivity? Congenital erythropoietic porphyria, porphyria cutanea tarda, and erythropoietic protoporphyria. So these 3 present with only photosensitivity. What are the disorders which present with both? Hereditary coproporphyria and variegate porphyria. Okay, hereditary coproporphyria and variegate porphyria present with both. How to remember this? Coproporphyria, meaning co. What is co? Simultaneous. So simultaneously, what is present here? Both photosensitivity and neuropsychiatric manifestations. So whenever the history says there is a child presenting with recurrent abdominal pain, with bizarre behavior which is cyclical, and there is also photosensitivity, then you should think of co, hereditary coproporphyria. And the other one is variegate porphyria. Remember, it has various manifestations, both photosensitivity and neuropsychiatric manifestations. Are you clear? Yes. So this is how you will be able to make a diagnosis given a history. If the history says only neuropsychiatric manifestations, think of ALA dehydratase defective porphyria and acute intermittent porphyria. Then there is only photosensitivity, think of congenital erythropoietic porphyria, porphyria cutanea tarda, and hereditary erythropoietic porphyria. No. And the last one is erythropoietic protoporphyria. What is the key for them? What key do you want, Pravi? And what are the conditions where you see both? Both is hereditary coproporphyria and variegate porphyria. Okay? A farmer, this is again a previous year question, July 2023 MCQ. A farmer sprayed a chemical in the pool which causes inhibition of complex 3 of electron transport chain. Identify the inhibitor. Okay. So whenever complex 3 is inhibited, it is either BAL, a 3-letter word which is BAL, or it is antimycin. It is either BAL or antimycin. But the clue is a farmer has sprayed a chemical. So it is antimycin. Do you understand this? Though there are two answers here, BAL and antimycin, farmer will not be spraying BAL. Do you understand that? So the answer is antimycin. So can we learn about electron transport chain inhibitors now? Are you all ready? Yeah, electron transport chain inhibitors. So for you to understand about electron transport chain inhibitors, first you need to know how these complexes are arranged, right? So we have 5 stationary complexes. Those 5 stationary complexes are numbered in Roman letter. So we have complex 1, complex 2, complex 3, complex 4 and complex 5. So what is complex 1? Complex 1 is NADH linked dehydrogenase. Complex 1 is NADH. Anwar, I told you BAL will not be sprayed by a farmer into a pool. Do you understand that? What is sprayed by a farmer on a pool? It is antimycin. That is the clue. Got it? So complex 1 is NADH linked dehydrogenase. That is, electron from NADH enters into electron transport chain through complex 1. Complex 2 is succinate dehydrogenase. Okay. Complex 3 is cytochrome B and C1. Okay. Complex 3 is cytochrome B and cytochrome C1. Complex 4 is cytochrome A and A3. Right? Complex 4 is cytochrome A and A3. And the last one is complex 5, which is ATP synthase complex, which I will not be showing you here. So these are the 5 stationary complexes. So can you all repeat this? What are the 5 stationary complexes? Complex 1 is NADH linked dehydrogenase. Complex 2 is succinate dehydrogenase. Complex 3 is cytochrome B and C1. Complex 4 is cytochrome A and A3. Complex 5 is ATP synthase complex. So these are the 5 stationary complexes. What are the mobile complexes? We have 2 mobile complexes. One is ubiquinone or Q, placed between 1 and 3. The other one is cytochrome C, placed between 3 and 4. Right? Q placed between 1 and 3. Cytochrome C placed between 3 and 4. Okay. So what is the direction of transport of electron? From NADH, electrons enter into electron transport chain through complex 1. From complex 1, electrons go to Q. So from Q, electrons go to 3. From 3, electrons go to C. From C to 4. From 4, the final acceptor of electron is oxygen. You understand this? From 4, the final acceptor of electron is oxygen. This was asked previously in FMG. Which is the final acceptor of electron and electron transport chain, all of you? It is oxygen. Okay, so this is for NADH. FADH2 electrons enter into electron transport chain through complex 2 or directly they go to Q. Okay, so FADH2 enters into electron transport chain either through complex 2 or directly to Q. From 2, electrons go to Q. From Q, don't you know the direction already? Can you all repeat it? From Q, these electrons go to 3, 3 to C, C to 4, 4 to oxygen. Are you clear about direction of transport of electron? Now about electron transport chain inhibitors. Inhibitor between complex 1 and Q. Yeah, between complex 1 and Q, electron transport is inhibited by number 1, amobarbitol. Yeah, amobarbitol, pyrisidin A. Second one is pyrisidin A and then rotenone. So tell me, what are the 3 inhibitors which inhibit electron transport between 1 and Q? Amobarbitol, pyrisidin A and rotenone. How can you remember this? Easy to remember. 1, the first alphabet is A, right? Between 1 and Q, the first alphabet is A. Don't you see that all 3 names have got something to do with A? Amobarbitol starts with A, pyrisidin A ends with A, rotenone. It is not vitamin A, but it sounds like vitamin A, right? Tell me, what are the 3 forms of vitamin A I told you? Retinol, retinal and retinoic acid. This is rotenone, which sounds like vitamin A. And even if you don't want to remember it that way, another easier way of remembering it is, in rotenone, the last 3 letters are 1. In rotenone, the last 3 letters are 1. So it inhibits electron transport between 1 and Q. Okay. Now, succinate dehydrogenase is inhibited by malonate. Succinate dehydrogenase is inhibited by malonate. Electron transport between 2 and Q. Yeah, electron transport between 2 and Q is inhibited by TTFA. 2 starts with T, right? 2 starts with T. Between 2 and Q is inhibited by TTFA and carboxyl. Between 3 and C is inhibited by a 3-letter word, BAL and antimycin. Okay, between 3 and C is inhibited by BAL and antimycin. Between 4 and oxygen, right? Between 4 and oxygen is inhibited by hydrogen sulfide, all common poisons. Between 4 and oxygen is inhibited by hydrogen sulfide, cyanide and carbon monoxide. Okay, hydrogen sulfide, cyanide and carbon monoxide. So can we repeat this, all of you? Answer please. Between complex 1 and Q is inhibited by what? 1 and Q is inhibited by amobarbitol, pyrisidin A and rotenone. Complex 2 or succinate dehydrogenase is inhibited by malonate. Electron transport between 2 and Q is inhibited by TTFA and carboxyl. Between 3 and C is inhibited by BAL and antimycin. Between 4 and oxygen is inhibited by hydrogen sulfide, cyanide and carbon monoxide. Got it? So what is the answer here? Which inhibits complex 3? A farmer sprayed a chemical. So what is it? It is antimycin. A person gives blood sample for plasma glucose estimation at 7 a.m. His last meal was a dinner at 8 p.m. the previous night. Jan 2022 MCQ. The major source of plasma glucose is between 8 p.m. and 7 a.m. How many hours have passed by? 11 hours. till 12 to 18 hours. Yeah, till 12 to 18 hours, the major source of plasma glucose is liver glycogenolysis. Do you understand this? Till 12 to 18 hours, the major source of plasma glucose is liver glycogenolysis. So let me help you answer this question by telling you few facts. How do you maintain plasma glucose? By 3 ways. The first one is dietary glucose. Second is liver glycogenolysis. Third is gluconeogenesis. There are only 3 ways to maintain blood glucose. One is dietary glucose. Second is liver glycogenolysis. Third is gluconeogenesis. Dietary glucose will maintain blood glucose till the first 2 to 2.5 hours after the previous meal. Suppose you have your lunch at 3:30 p.m. after the session. Okay, the first 2 to 2.5 hours till 5:30 to 6, your dietary glucose will maintain plasma glucose. After which contribution from dietary glucose to maintain plasma glucose decreases. But you cannot afford to reduce your blood glucose because your brain is dependent on glucose. So how do you maintain plasma glucose? If diet cannot provide glucose, then liver comes for the rescue. Liver glycogenolysis begins. So tell me, when does liver glycogenolysis begin? Liver glycogenolysis begins 2 to 2.5 hours after the previous meal, and it can maintain blood glucose till 12 to 18 hours of starvation. Do you understand this? It can maintain blood glucose till 12 to 18 hours of starvation, after which it has to be gluconeogenesis. So when does gluconeogenesis begin? Gluconeogenesis begins 6 hours after the previous meal. Though gluconeogenesis starts 6 hours after the previous meal, till 12 to 18 hours, what is the major source of plasma glucose? It is liver glycogenolysis. Only after 12 to 18 hours, it becomes gluconeogenesis, which is the major source.
Okay.
Do you get it? So between 8 p.m. and 7 a.m., it is only 11 hours. Till 12 hours, what will be the major source? It is liver glycogenolysis. Are you clear?
And changing time. And
How much more time? We will discuss about glycosphingolipidosis, after which you can all leave. Okay? Because glycosphingolipidosis are often asked about, right? So let's discuss about this. A young boy is having difficulty in breathing while running, which means, very good all of you, which means the person is presenting with neurological manifestations. And the person is unable to rise from the squatting position. His fundus examination image is provided below. What does the fundus examination reveal? Fundus examination reveals cherry red spot. So it's a case of neurological manifestations with cherry red spot without hepatomegaly. Have they given anything about organomegaly? No. So that is Tay-Sachs disease. Do you understand this? That's called as Tay-Sachs disease. But how do I exclude the other choices? Because all these are also lipid storage disorders. They will also present with neurological manifestations. They can also present with cherry red spot, right? So how do I exclude other choices? Let me tell you few facts about glycosphingolipidosis. The first fact is cherry red spots are absent in KGF. Yeah, cherry red spots are absent in KGF. Did you all see this movie? Cola Goldfield, right? Here KGF stands for Krabs disease, Gaucher's disease, Fabry's disease.
correct.
Krabs disease, Gaucher's disease, Fabry's disease, no cherry red spot. Okay? Few more facts about glycosphingolipidosis. So now tell me the answer. Because there is cherry red spot, what are the conditions that you can exclude? Krabs, Gaucher's and Fabry's. So what are you left with? You are left with Tay-Sachs disease. Okay? Now, few more mnemonics. Okay? No mental retardation in GF. No mental retardation in GF. We usually say that girlfriends are smart. Don't we say that? Yeah, girlfriends are smart. So no mental retardation GF. What does GF stand for here? Cautious and Fabry's. Okay. The next one, just now I told you, no cherry red spot in KGF. So no cherry red spots in crabs, cautious and Fabry's. No organomegaly. Organomegaly is never a feature. Yeah, organomegaly is never a feature of Tay-Sachs and crabs. Okay, organomegaly is not a feature of Tay-Sachs and crabs. Now that we have started discussing about Tay-Sachs, you need to know about Sandoff as well. Tay-Sachs and Sandoff. Why do you have to learn about these two disorders? These two disorders are collectively called as GM2 gangliosidosis. So GM2 gangliosidosis will include Tay-Sachs and Sandoff. Let me tell you the differences between these two conditions. Because even in standard textbooks, it's very difficult to understand differences between these two conditions. I'll help you understand that. The first difference is which gene defect causes Tay-Sachs. Tay-Sachs is caused by the defect of hexosaminidase A gene. Sandoff is caused by the defect of hexosaminidase B gene. What does A gene code for? A gene codes for alpha subunit of hexosaminidase enzyme. B gene codes for beta subunit. You understand this? A gene codes for alpha subunit, B gene codes for beta subunit. Now about the enzyme. We have two hexosaminidase enzyme. One is hexosaminidase A enzyme, the other one is hexosaminidase B enzyme. A enzyme is made up of alpha beta subunit. B enzyme is made up of beta beta subunit. Do you understand this? A enzyme is made up of alpha beta subunit. B enzyme is made up of beta beta subunit. A enzyme helps in metabolizing GM2 ganglioside. Yeah, A enzyme helps in metabolizing GM2 ganglioside. B enzyme helps in metabolizing globoside. Have you all memorized it? Hexosaminidase A enzyme, alpha beta subunit, B enzyme, beta beta subunit. A enzyme metabolizes GM2 ganglioside, B enzyme metabolizes globoside. In Tay-Sachs, when alpha subunit is defective, only one enzyme will be defective. So, in Tay-Sachs, only hexosaminidase A enzyme is not working. In Sandoff, beta subunit is defective. When beta subunit is defective, both hexosaminidase A enzyme and B enzyme will not be working. Do you understand the difference? In Tay-Sachs, only hexosaminidase A enzyme is defective. In Sandoff, both A enzyme and B enzymes are defective. So, which lipid will accumulate? I said A enzyme metabolizes only GM2 ganglioside. So, in Tay-Sachs, only GM2 gangliosides accumulate. In Sandoff, both GM2 gangliosides and globosides accumulate. Okay. Clinically, organomegaly is never a feature of Tay-Sachs. Sandoff sometimes presents with organomegaly, sometimes does not present with organomegaly. So these are the differences between Tay-Sachs and Sandoff. Can you all repeat this? In Tay-Sachs, which gene is defective? Hexosaminidase A gene is defective. In Sandoff, B gene. A gene codes for alpha subunit, B gene codes for beta subunit. In Tay-Sachs, only hexosaminidase A enzyme is defective. In Sandoff, both hexosaminidase A and B enzymes are defective. In Tay-Sachs, only GM2 gangliosides accumulate. In Sandoff, both GM2 ganglioside and globosides accumulate. Tay-Sachs never present with organomegaly. Sand-off sometimes presents with organomegaly, sometimes no. Okay, so that's about Tay-Sachs and sand-offs. Now, one more fact is beta-glucosidase defect. Beta-glucosidase defect causes Gaucher's disease. Okay, beta-glucosidase defect causes Gaucher's disease. Did I tell you that alpha-glucosidase defect causes Pompey's disease? Did we learn that? Acid maltase or alpha-glucosidase defect causes Pompey's, whereas beta-glucosidase defect causes Gaucher's. So Gaucher's disease is something which is repeatedly asked about. I'm going to tell you all about Gaucher's disease. First, tell me which enzyme defect? Beta-glucosidase defect. When this enzyme is defective, glucosyl cerebroside accumulates. What accumulates? Glucosyl cerebroside accumulates. And this glucosyl cerebroside is a feature of RBC membrane and platelet membrane. So in Gaucher's disease, both RBCs and platelets have abnormal membrane. So they will be engulfed by macrophages. Because macrophages engulf all RBCs and platelets, what will you see? You will see refractory anemia and thrombocytopenia. So tell me, what will be the presenting feature of Gaucher's? It presents as refractory anemia and thrombocytopenia. After macrophages engulf these cells, these cell membranes, right? These cell membranes will accumulate like fibrils. And these fibrils of membranes is responsible for crumpled tissue paper appearance. The abnormal cells membrane will accumulate, which makes it look like a crumpled tissue paper. So can you see that image? Yeah. So this is how an image will be shown, and the history will say there is a child presenting with refractory anemia and thrombocytopenia. Bone marrow biopsy revealed crumpled tissue paper. Do you see blue color cells, all of you? Blue color cells with crumpled tissue paper. This is crumpled tissue paper appearance. And because there is refractory anemia, there will be compensatory erythropoiesis in the bone. And that causes bony erosion and bony pain. It causes bony erosion, bony pain. Compensatory erythropoiesis happens in extramedullary tissue, and that causes hepatosplenomegaly. And enzyme replacement therapy is available for Gaucher's. Right? Enzyme replacement therapy is available for Gaucher's. So can you all tell me all about Gaucher's? There is 90% probability that you are asked about Gaucher's, right? Because this they have repeatedly asked in FMG. So tell me about Gaucher's. It's caused by the defect of beta-glucosidase. Gaucher's, there is 90% probability that you are asked about Gaucher's, right? Because this they have repeatedly asked in FMG. So tell me about Gaucher's. It's caused by the defect of beta-glucosidase. When beta-glucosidase is defective, glucosyl ceramide or glucosyl cerebroside accumulates. That causes anemia, thrombocytopenia. Bone marrow biopsy reveals crumpled tissue paper. There is bony pain, bony erosion, hepatosplenomegaly, and enzyme replacement therapy is available. Okay. Answer this. A child presented with refractory anemia. Below is provided the smear of bone marrow biopsy of the child. The probable enzyme deficiency is. Yes, Vanshika Saini. Just watch this session. Learn all the facts that I told you here. Repeatedly revise it. Work out all previous year questions. That should be enough. Yeah, the answer is beta-glucosyl cerebrosidase defect. Okay. So I hope I've covered most important questions, most previous year questions, and all clinical case-based MCQs have been discussed. Okay. So I will be sharing the PDF also, and you can download the PDF and you can revise it. Okay. So previous year question is essential, and do not underestimate FMG paper. Learn the subject conceptually. Do not accept it when somebody says that biochemistry is a pre-clinical subject. Did we discuss about so many clinical conditions today? Yeah. So if you don't understand biochemistry, most of the subjects will be very difficult to understand. So learn biochemistry conceptually. Okay. Thank you. Tay-Sachs and Niemann-Pick, both present with cherry red spots, both present with neural